Very good afternoon to everyone. Welcome back to the GERICON 2021 conference, virtual conference. Welcome back after the lunch. And I would like to request Dr. Chandramohan sir for handling this session with Yasir sir.
Yes, madam. Thank you, Duna madam. Yes, I should say thank you for Sarat sir. In his absence, I take a responsibility to chair this session. And thank you, Sarat sir. And I welcome now Muhammad Yasir sir, who is having 22 years of experience in the field of healthcare in India, Kuwait, UAE, Oman, and Qatar. He lived in India and all the places he mentioned, and his very keen interest is expertise in operations, public relations, and HR strengthens his position. His education is Master in Physiotherapy, Master in Hospital Management, and Certified in Occupational Health Physiotherapy. Currently, he is pursuing PhD at Lincoln University, Malaysia. Also, currently he is working under Qatar Petroleum, Head Physiotherapy and Rehabilitation Services, also consultant in Armed Forces Hospital, Kuwait. And also he worked as associate professor in Father Muller's Medical College in India. And his social associations are, he is a chairman, Indian Physiotherapy Forum, Qatar, IPFQ Advisory Board, and member, Indian Business and Professionals Forum, Qatar, IBPC, and member, Indian Culture Center, Qatar, ICC, and member, Indian Community Benevolent Forum, Qatar, ICBF. And he represents India in many of the boards. I welcome Muhammad Yasir sir and request him to start the session, please.
Good evening and good afternoon, everyone. And thank you so much, Chandramohan, for a very generous introduction. And this time, one interesting factor for me to join this conference is this is in connection with the college in my hometown, where I am currently residing and living. So that is also a factor for me to present here today. And basically, I'm just trying to attempt, because I'm not a clear educationalist like many of you are here. So I'm just trying to understand or to share a couple of my views, which I had, in hand, and the way, what is the background I pursued to do the PhD in this subject itself. So having said this, we always consider or always looking into the physiological level or the outward level, but we are not exploring much as physiotherapists into the molecular level of the problem, what is happening. So I will briefly just go through the observations, what we are seeing, and what could be the possibilities we can explore, and the future students also can do that way in this direction, so that a bit more comprehensive prevalence studies happen in India will be beneficial. So this is what an introduction I would like to tell. So I will finish within the prescribed time. So having said this, as you are aware of the introduction given to osteoarthritis knee, as we all know, osteoarthritis can no longer be labeled as simply as a degenerative joint disease, but it has a lot of other factors as well. A lot of evidences supports that an important role for the systemic inflammation. Traditionally, we are all seeing about this is a non-inflammatory disease, but as the investigations we got, or we get into more of the informations. Now there is a systemic inflammation also promoting the structural damage in OA knee. So this is what the study says. And a lot of numerous cytokines, chemokines, or other pro-inflammatory factors have been identified in OA synovial fluid. So how these are affecting the destruction of the cartilage in terms of the other production of the mediators like interleukin 6, interleukin 8. So these are the various biomarkers which result in the degenerative changes of cartilage and contributing to the development of the symptoms. Since knee arthritis is a considerable public health issue, a less expensive community-based approach, especially in our countries like India, would be necessary to minimize functional disability and the impact of the disease in the society. So this is what we are trying to address here, basically. So what is the redox imbalance? The oxidative stress is viewed as an imbalance between the production of the reactive oxygen species, which is broadly called as ROS, and their elimination by protective mechanisms. So when there is a weakened antioxidant defenses, it leads to an imbalance, which can lead to chronic inflammation. So as osteoarthritis is a chronic degenerative joint disease characterized by loss of cartilage, articular cartilage, bone alterations, and joint inflammations. So these are the various set of biomarkers present in the serum as well as in the synovial fluid. So this is the biomarkers which I would like to talk and how this has been affected by the exercise. So these are the various inflammatory markers. We can see the C-reactive protein, interleukin 6, tumor necrosis factor alpha, oxidative stress markers like melanoldehyde, antioxidants like glutathione, gluten. These are seen in the synovial fluid also. So these are the set of biochemical markers what we can see. Why osteoarthritis is an age-related disease? Okay, OA is the most common joint disorder in the world and one of the most common source of pain and disability in the elderly. So it has a multifactorial condition, and with the aging as well as the obesity also contributes more. So it is estimated approximately 10% of the world population age 60 years or older has symptoms of OA, and women are more affected than men. So aging changes observed in the cells as intracellular matrix, as you see, of joint tissues likely to increase the accessibility of older adults to OA when other OA risk factors are also present. So again, it is just stressing the point on the OA is not simply a mechanical wear and tear, but it is an active biological process of matrix degradation mediated by cells within the joint. So if you take the prevalence in India, a self-reported prevalence of diagnosed major health conditions in older age, you can see it has in bone and joint diseases having a prevalence with the various age starting from less than 45 years up to 75 plus years. You can see the percentage here, like starting from 9.5 and it varies between 21.2% into 19.4%. So it has a cost prevalence in India, as we all know, because we are all coming from various parts of India. So definitely we will be knowing, or you will be knowing much more than me since you are all practicing in that part of the world. So what is the relationship between the exercise and the oxidative stress? The relationship between the exercises is extremely complex. So what major study says a moderate training is state beneficial for oxidative stress. So the operative choice of guided home program that could reduce the knee pain and improve physical function in people with OA knee. So these exercises, which have to be given in a calculated manner, requires real-time monitoring of the joint inflammatory conditions for performance optimization. So there is a definite relationship between the oxidative stress and the exercise. So a study shows that potential adaptations to exercise training in the improvement in inflammation. As you see here, we can see there is a mechanism by which the exact mechanism by which the physical activity may reduce inflammation are not entirely understood. There are some data pointing to the factors that may contribute. In effect, repeated bouts of muscle contraction leading to improvement of inflammatory process, because these factors could be a shift in the monocyte phenotype, specifically reductions in the immune cell production of inflammatory mediators, and whatever occurs in the locally in the exercised skeletal muscle, there is also some changes happen. So there is a potential adaptation to exercise training which can improve the inflammation. So a couple of investigators who from Denmark, UK, as well as one more place I just forgot, they made explore the effect of exercise on molecular biomarkers associated with cartilage and inflammation in individuals at risk or with a confirmed OA knee. So they performed a literature search through September 2017, which included a total of 12 randomized controlled trials. The trials involved 57 study comparisons at 4 to 24 weeks following an exercise therapy intervention. So the investigators concluded that exercise therapy is not harmful in individuals with ONE, and it does not increase the concentration of molecular biomarkers linked to cartilage turnover and inflammation, which are potentially involved in the progression of ONE. So basically, they are saying future studies are warranted that obtain in synovial fluid also, rather than focusing on a set of biomarkers. So many people have done study on interleukin or TNF alpha like that. But instead of focusing on the individual biomarkers, they also recommends to focus or set biomarkers in the synovial fluid also. So why we are concentrating much on the self-management? Because as you know, this is a chronic condition where people are going into disability or they lack their life quality of life as well. So self-management or self-guided home program definitely reduces symptoms, improve quality of life, helps people to be more active and independent, provide a non-pharma treatment protocol, and patients become their partners in their own health. So this is basically why self-management is we are stressing on that one. So the benefits, as you all know, reduces pain, fatigue. These are the various benefits apart from being the other therapeutic effects. Basically, we want to maintain a guided or a constant, consistent home program or home-based intervention for people to be healthy and active. So based on these factors and the suggestions, we embarked on a study in Narayana Medical College, Nellore. So which is having a 3 years study, which is on started. So the aim of the study is to find the relationship between the oxidative stress, inflammatory markers, and intervention of exercise in osteoarthritic patients, neo-osteoarthritic patients. So as I discussed earlier, the objective is to find the oxidant, antioxidant markers, inflammatory markers in osteoarthritis serum, as well as in the synovial fluid. Many studies are done on the blood serum, but we are including here as a synovial fluid also. Okay, and both pre and post therapy measurement of the various biomarkers has been taken or taken according to the as the study progresses. So basically, we are factoring around 300 people with an age of 14 to 60 years, which may extend up to 70 years, maybe depending on the people that are involving here. So the couple of samples, are identified, and this is happening in Nellore Medical College, and we have the exclusion criteria because chronic inflammatory disease, total knee replacement, lower limb amputation, and these are the kind of exclusion criteria we have been adopted to this. So this study basically happening between the central laboratory of Narayana Medical College Nellore as well as the ortho department. So this is the methods what we will be assessing the couple of set markers rather than the individual inflammatory markers, which we are seeing here, like inflammatory markers, oxidative stress markers, and the physiotherapy assessment tool to monitor the function. One is WOMAC questionnaire we are using, as well as the pain intensity. So all these measures are taken before and after the intervention. The sample collections, we are when one is the blood sample is collected in 10 millivenous collected from the study objects in a fasting status. And synovial fluid also we are collecting through the orthopedic surgeons of the orthopedic department. So the exercise intervention, I'm not going to talk here in terms of what is the different exercise what we are in, but basically I just want to give a what all the sets or what all the ingredients of the home-based program. It will be on the ROM exercise, practice balancing, stretching, endurance kind of low impact aerobic exercises. So basically what we will be looking at, these exercise or programs should be designed to maintain the improve the strength of the muscles acting around the knee and hip as well, the range of motion at the knee joint and locomotor function. Okay. The training consists of 4 sessions lasting approximately 30 minutes per week in their respective arms, and follow-up is scheduled at monthly intervals for 6 months. So this is the study we are embarking, and this is required. This is another 2 more years is required to complete the study. And accordingly, what we are expecting the outcome from the various studies, what we have observed, as well as in terms of our prevalence, moderate exercise is stated to decrease the oxidative stress and reduce the inflammation, which will further prevent the degeneration of the cartilages. And exercise training has been shown to have an anti-inflammatory effect as well, reducing the resting level of biomarkers. So this is what we are expecting with this study. So this is a points which I would like to share with the team as of now. And here I conclude my small presentation with regard to this redox imbalance and effect of exercise. Thank you, and over to Chandramohan.
Thank you, sir. Thank you for a wonderful information shared regarding biomarkers in synovial fluid and self-management and exercise interventions. And yes, I request Duna Madam to check any questions.
Sir, no questions have come yet. I am waiting.
And participants who have joined in Zoom and delegates who have joined in YouTube, in Zoom, can ask questions if any. Write in chat box. Any questions, madam?
No questions have come yet, sir. Only attendances are joining.
Thanks for that biomarkers related information, sir, because we are planning for a regenerative physiotherapy, regenerative rehabilitation conference in another 3 or 4 months. It gives some insight. So how to have some idea about biomarkers in synovial fluid and all those things. And any questions from Zoom? No. No questions, sir. Maybe less participants in YouTube and also post-lunch session. People may have some business. And thank you so much for wonderful information shared. And we are moving on to the next topic. Kindly stay with us, sir.
Sure. Thank you so much.
Yeah, thank you, sir. Over to Duna, madam.
Yes, has ma'am joined? Manisha ma'am joined?
Yes, yes.
Yes, I am there.
And Shyam sir?
Yeah.
Thank you, Chandramohan sir.
I'm here.
I'm really, pardon sir?
I'm here already.
Okay, thank you, sir. Thank you. And thank you, Chandramohan sir, for giving me this opportunity to invite our respected chairperson for this 6th topic of this scientific session post-lunch. And I would be really delighted to invite her. Dr. Manisha Rathi ma'am is a professor of Dr. D.Y. Patil College of Physiotherapy, D.Y. Patil Vidyapit, Pune. She has done her PhD in physiotherapy from D.Y. Patil Vidyapit, Pune in 2016-17. Madam is Master in Physiotherapy, MPhD in General and Community-Based Physiotherapy and Rehabilitation in year 2007. And ma'am has secured the first rank in the university. And madam has also achieved a course in yoga in 2008. She is having total work experience of 23 years and teaching experience of more than 21 years. Madam has also achieved many different awards from National Television Channel Doordarshan Sahyadri Award to Best Teacher Award, Significant Achiever Award, and many more. She has presented many different papers as resource person and as a guest lecturer. She has lots of publications, total of 53, citations 61, and she has index of Google Scholar at 5. And I welcome you, ma'am.
Thank you so much, madam. And I am really thankful to Dr. Chandramohan for inviting me as a chairperson for this session. Thank you so much, the whole ExRx team India, for when organizing such a wonderful conference on a topic, gerontology. So it was a really great thing that organizing such a good conference on such wonderful topic. Thank you so much for inviting me. And I would like to introduce today's speaker, Dr. Shyam Krishnan. He is Assistant Professor Senior Scale at Kasturba Medical College, Mangalore, Manipal Academy of Higher Education. In his 14 years of experience, he has authored or co-authored 30 publications in national as well as international peer-reviewed journals. He has done MPT in CBR and from Manipal University itself from 2007. And his area of interest is occupational health, ergonomics, community reintegration, biomechanics, exercise physiology, technology, enhanced rehabilitation and research. So I would like to invite Dr. Shyam Krishnan for this topic. Welcome and hand over to you, Dr. Shyam.
Thank you very much, ma'am. Thank you for the generous introduction. And I would, at the outright itself, I would like to express my immense gratitude to Dr. Chandramohan for having invited me for this and having given me a platform to share stage with such eminent people. And the thing is that my session is actually on degenerative joint disease. And a part of the things which I wanted to speak has been spoken by Yasir sir. So, I had to basically trim down my slides when this presentation was going on. So, I would basically touch upon certain things. And one more thing is I would not be strictly following what I have put on the PowerPoint. I have put what I'm speaking on the PowerPoint, but I would be speaking more. I'm comfortable doing that than following the PowerPoint and reading out from that. So, I think I'll share the screen and I can start the presentation, sir. Can I?
Yes, sir, please.
Sure, sir. Please share the screen.
One second. So, I would basically, excuse me. So I'm going to essentially talk about degenerative joint diseases, and what I'm going to speak about is, so degenerative joint diseases as a whole, it is impossible for me to speak about the management or specific exercises or specific evaluation for that matter. But what I will be trying to cover is some key points which needs to be kept in mind, regarding the genesis of these conditions, how we are going to evaluate them and how we are going to manage them. So that's what my whole talk would be about. And I would try to touch upon the things which Dr. Yasir had actually spoken in the previous lecture. That is how our assumption of a degenerative joint disease being just a wear and tear, or we assume our body is like a machine, and it's an oversimplification. Now, the difference between a machine and a living tissue would be the dynamism which is involved. Our body is capable of self-regulating and maintaining homeostasis by regeneration, by repair, etc., which a machine would not be able to do. So it is to an extent it is right from a mechanical systems point of view to view our body as a machine, but to another extent it is wrong to do that because of the dynamic nature of our tissues in regeneration and repair. So on that note, I would just begin my lecture on degenerative joint diseases. So essentially the musculoskeletal diseases in elderly which we come across have been classified there are various classifications which are available. Age specifically, the conditions which are seen have been classified under various umbrella terms. The major ones are inflammatory synovitis. The inflammatory synovitis can be because of a rheumatoid or rheumatism. It can be because of gout or pseudogout or septic arthritis. So wherever the synovial membrane of the synovial joint is involved primarily, and there's an inflammation arising out of the synovial tissue, it is called as an inflammatory synovitis. It could be autoimmune, infective, inflammatory, or any kind of synovitis. The second classification is basically degenerative arthritis, what we are going to speak about now, the degenerative joint diseases. Third is vasculitis and connective tissue disorders like polymyalgia rheumatica and systemic lupus erythematosus and all. Then soft tissue rheumatism, which could again inflammatory disorders, so the soft tissue which can happen, and obviously various diseases or musculoskeletal issues associated with the spine. So among these, how do we define degenerative joint disease is the question. So essentially, it's a bony inflammation. To put it very simply, a degenerative joint disease is a bony inflammation of joint or joints. Now, technically, to classify a disease as a degenerative joint disease, there is involvement of three typical structures. The primary one being the hyaline cartilage, which lines the joint, which is otherwise called as the articular cartilage. Second is basically the subchondral bone, the bone which lies underneath that particular cartilage. And third is the synovial membrane. Now, there are various schools of thought about what gets involved first, but the only consensus regarding the origin of the condition is basically the hyaline cartilage or the articular cartilage being the first to be involved, followed by the involvement of subchondral bone as well as the synovial membrane. So it's a heterogeneous pathological state with variety of causes and pattern of expressions. And ultimately, to put it in terms of like musculoskeletal system or joint as an organ, like we attribute the failure of the kidney as renal failure, the failure of heart to basically maintain the cardiac output as heart failure. So in that same analogy, if you look at it, a degenerative joint disease essentially leads to a joint failure. Now, what do you mean by a joint failure? Is essentially the function of a joint is to act as a mechanical link between two rigid levers to transmit forces so that we can interact with the environment. Now that interaction can be application of forces or generation, it's essentially application of forces, either pulling, pushing or shearing forces, which needs to be generated by our interaction with the environment. Now, a joint failure occurs when this mechanical linkage is incapable of functioning in a manner which essentially permits efficient force transmission between two rigid levers. So degenerative joint disease is a condition which essentially leads to improper joint function or failure of joint to function as a mechanical link between two rigid bony segments to transmit forces. As a result, depending upon where the joint disease is manifested, there can be a myriad of functional limitations, which essentially could lead to participation restriction. If you look from the perspective of the ICF, International Classification of Functioning, it essentially could lead to a restriction of participation. Now, degenerative joint disease is otherwise termed as osteoarthritis. The term osteoarthritis is interchangeably used with the degenerative joint disease because that is what it is. The pathophysiology is essentially that of osteoarthritis. Now, I have put the picture of an osteoarthritic knee here, but and that is the most common joint which comes to our mind when we speak about osteoarthritis, but it is not so. Okay, as we go subsequently, we will be able to see various pathological states where multiple joints could also be affected. Now, coming to the epidemiology, the epidemiology causes and predisposing factors. Now, I'm not going to speak about the prevalence and incidence and all those things because already been covered by Yasir sir. But if you look at the causes and predisposing factors, we have factors which are modifiable and there are factors which are non-modifiable. As in the case of any condition which is acquired, okay, there can be factors which are which can be modified by intervention, and there are factors which cannot be modified by intervention. The strongest factor, this factor which cannot be modified by intervention, is essentially at an advanced age. Now, that's the reason why this condition becomes relevant in the context of today's conference per se. So, advanced age is the strongest risk factor. Now, before we go into further, I want to basically talk about osteoarthritis in terms of two specific stages. Now, you can classify osteoarthritis or degenerative joint disease into a radiographic osteoarthritis and a symptomatic osteoarthritis. Now, a radiographic osteoarthritis is that kind of a degenerative joint disease where there are no symptoms or the patient doesn't experience the effect of the disease per se. And as a result, there may not be functional limitations, there may not be limitations with participation. Okay, but there would be radiological evidence of a degeneration having taken place in the joint. That means there could be, for example, a subchondral sclerosis, there could be degeneration, there could be formation of osteophytes, there could be narrowing of joint space. But it may not be symptomatically visible, or the person may not be experiencing a symptom out of it. That is radiographic osteoarthritis. And symptomatic osteoarthritis is basically like a person experiences a symptom. And usually a symptomatic osteoarthritis would have associated radiological factors, at least in the advanced stages. And both the kinds of osteoarthritis, that is whether it is radiographic or symptomatic osteoarthritis, there is an increased prevalence of these after the years of 50 years in males and 40 years in females. Now, so that means the onset is much earlier than usually what we think of it as. We think of it as a disease of middle old or old, but it is actually in the 6th decade that it begins in males, and in the 5th decade it begins in females. Now, again, we would be considering radiographic, when we talk about osteoarthritis, we would be considering the osteoarthritis of the lower extremity as the most common osteoarthritis. But evidence shows that if you just consider radiographic osteoarthritis, that is osteoarthritis where there are radiographic changes without symptoms, OA of the hand is the most common form, which is followed by knee and hip. Now, if you only consider the symptomatic osteoarthritis, the greatest prevalence is seen in knee followed by hip. And there is variability in the prevalence of others, but hand usually comes as the next highest ranked in most of the populations in terms of osteoarthritis. Now, it's the order of prevalence is common to both the genders. Now, the symptomatic involvement of hand is seen to increase post-menopause in women. So, those women who have radiographic osteoarthritis, they tend to have a symptomatic progression of the disease post-menopause. That is, once the endocrinological dysregulation of menstruation or dysregulation of menstruation happens, that is when the disease progresses to become symptomatic. Now, the other predisposing factors are basically a history of joint trauma or non-traumatic biomechanical factors. Now, long-standing inflammation with joint swelling and pain. Now, it could arise out of a traumatic condition. So, for example, a person tends to hurt a soft tissue associated with the joint, or a connective tissue associated with the joint, and as a result, there is a long-standing swelling or inflammation of it. For example, a ligament tear of the knee, or or any of the joints for that matter, which leads to a long-standing swelling and inflammation, is considered to be a strong predictor of osteoarthritis later on in life. There is an association between a traumatic or a non-traumatic inflammatory disease of the joint happening and osteoarthritis developing later. Now, certain surgical procedures, something like meniscectomy, which might be might be the consequence of trauma, essentially increases the odds of getting an osteoarthritis later in life. Especially meniscectomy, even if it is a partial meniscectomy, it increases the odds of having an osteoarthritis later in life by 6 times when compared to a person who hasn't undergone a meniscectomy. Now, obesity and female gender, they are considered as a separate factor per se, but obesity leads to excessive joint loading. Okay, because that's a biomechanical factor behind obesity. That is, it leads to excessive loading of the joints, which can essentially cause greater reaction forces to be generated, and those reaction forces can accelerate the degenerative process which could occur. Now, occupations or sports which are related to repetitive occupations or sports related repetitive trauma, like if you are involved in an activity which predominantly increase repetitive lifting or repetitive application of higher forces, like certain athletic events like hammer throw or pitching in baseball, etc., are essentially associated with osteoarthritis of some of the involved joints. So repetitive trauma, which might be related to occupational sports, is actually a predisposing factor for developing osteoarthritis. Now, though we would basically, like, it is there is a mysterious consensus among healthcare workers that intense exercise training, like excessive weight training, like you do squats with a lot of weight supported on your body, or like excessive like leg extension exercises with loaded with weights, etc., might lead to osteoarthritis. Now, there is no evidence, empirical evidence, supporting that particular notion. Relational association between intense exercise training is not proven per se, but it doesn't mean that it could not, because anecdotally it essentially could lead to degenerative joint diseases later on. So exercising at an intensity which is very high, okay, could potentially lead to degenerative joint disease later on in life, but there is no evidence for it as of now. Now, if you have a joint malalignment which is non-traumatic, for example, like you have a hind foot pronation because of which there's a tibial internal rotation, because of which there's a genu valgum. So that essentially leads to a difference in the way in which weight is borne through the joint. The line of gravity when it passes through the joint, essentially the location of the line of gravity is altered when you have a malalignment of the joint. And since the line of gravity would be altered, there would be definitely an alteration in the location of the reaction force which passes through the joint as well, which can essentially lead to accelerated degeneration of certain parts of the joint. So a malalignment of the joint needn't be a deformity. It can be a deformity, or it could be like a closed kinetic chain malalignment, like a hind foot supination or a hind foot pronation, or which leads to basically realignment of the other parts of the kinetic chain, can essentially lead to osteoarthritis later in life. Okay, and a varus or a valgus laxity is an example of the same. It could lead to an osteoarthritis later on in life. Now, we come to two factors which are modifiable, like obesity is associated with the prevalence of knee, hip, and hand osteoarthritis. Now, the thing is that the statistics say that a quintile is basically, if you divide a population into 5 parts, rather than dividing into quarters, 4 quarters, you divide it into into 5 parts per se. The person in the highest quintile of weight has 10 times greater odds than someone in the lowest quintile of weight. That means, among, say, imagine like you are taking all 60-year-olds. Now, the person who the highest 1/5 of the weight, if a person falls in that category, they have 10 times greater odds than someone who is in the lowest quartile, lowest quintile, to basically get an osteoarthritis. That's the odds of getting an osteoarthritis when your body weight is high. Now, the reason why body weight, essentially increased body weight or obesity leads to an osteoarthritis is fairly simple to think about, in the sense, when you have a greater weight, when you tend to apply a greater force on the joints, or the joints have to bear a greater force, and as a result there can be greater degeneration over a period of time. But the mechanical aspect of having an obesity is basically suspected, but it is not conclusive that that is the only reason why obesity can lead to osteoarthritis. The reason being, it is understandable if you see higher prevalence of osteoarthritis in obese people, especially in the lower extremity. It can be osteoarthritis of knee, it could be osteoarthritis of hip, etc. But there is a strong association between osteoarthritis of the hand and obesity. Now, what is assumed is, like Dr. Yasu was talking in the previous session, the endocrinological variations which occur with obesity is obviously a metabolic syndrome. There is definitely there is also there is also dysregulation of various kinds of metabolic processes, there is dysregulation of how insulin or insulin-like growth factor interacts with the receptors. So, all these factors have been proposed to essentially lead to certain kinds of scenario which promotes senescence. Now, later on, we'll come to see a terminology called as chondrosenescence, which is aging, not chronological aging, but like, the cartilage becoming older, or like as we see, senescence is essentially not related to chronological age, but how our body system's ability to maintain homeostasis is decreased. So, obesity essentially promotes senescence in multiple kinds of tissue. Like it has certain pro-inflammatory functions too, and that is assumed to be behind the increased prevalence of osteoarthritis, which is seen in obese people, not just to the joints which are directly falling in the line of fire of a higher body weight being taken down, but also in joints which may not be weight bearing, like the joints of the hand. Now, muscle strength has essentially been, for example, cortical muscle strength is actually considered to be a causative factor, or cortical muscle weakness is considered to be a causative factor as well as a consequence of osteoarthritis of knee. Now, muscle strength has been found to be a strong predictor of osteoarthritis. That is, people with sarcopenia tend to have a degenerative joint disease more. So, so sarcopenia essentially affects sarcopenia is essentially the pathological, the age-related loss of muscle mass as well as muscle function. And it is seen that people who tend to have loss of muscle strength, they tend to have a higher predilection for osteoarthritis, especially in the lower extremity joints. So, muscle strength has been associated with development of osteoarthritis later on in life. So, now coming to basically taking the main factor for today's discussion, that is age as a risk factor for osteoarthritis. So essentially what happens is that aging leads to the senescence related changes. That is, there is decreased proliferation of the specific connective tissue cells, for example, chondrocytes, myocytes, and other kinds of the cells which essentially protects the joints or maintains the joint integrity and function. There is a decreased proliferation of that. There is blunted anabolic response. Anabolic response is essentially that response which builds up materials, for example, protein synthesis or synthesis of synthesis and polymerization of various kinds of connective tissue components. Now, those anabolic responses are blunted because of aging. They can be in oxidative damage, and there is increased apoptosis, that is, programmed cell death increases, but the regeneration of cells with respect to apoptosis goes down. The ratio is altered. Now, the mediators for these changes could be advanced glycation end products and receptors, the inflammatory dysregulation which happens with aging, which has been factored in for various kinds of changes which you see with aging, including loss of muscle mass, and the degradative enzymes which are produced as a result of inflammation. So, all these essentially can lead to altered biomechanics. It can lead to matrix degradation and tissue injury, and it can lead to an incomplete or inappropriate repair, essentially leading to something which is called as osteoarthritis. Now, the classification of osteoarthritis is fairly simple. Like, if you don't know why it has happened, it is basically idiopathic, or it is called as primary osteoarthritis. See, for example, somebody comes to you because of a knee pain, and there is no obvious reason. The pain has insidious onset. It is not related to an incident of a trauma or anything. The person doesn't have a history of trauma in his younger age or something. Okay. Or there is no history of a rheumatoid arthritis or other kinds of inflammatory joint diseases. And then, if you tend to diagnose him as an OA, then it would basically fall under primary osteoarthritis. That is, it is idiopathic in nature. Now, the secondary osteoarthritis essentially happens secondary to factors which could affect joint integrity. It could be something like a rheumatoid arthritis or a rheumatism, or it could be a trauma or any factor which essentially which obviously lead to an alteration in joint integrity, and that leading to an osteoarthritis would be considered as a secondary osteoarthritis, to put it very simply. Now, we come to the pathophysiology of osteoarthritis before we go to the management. So I told essentially there are three structures. Which are involved, or three joint related tissue which are involved in degenerative joint disease or osteoarthritis. The primary being the articular cartilage, okay, the second being the subchondral bone, and the third being essentially the synovial membrane. So we are going to see how it does, how it actually like effectively manifests in terms of pathology. So the articular cartilage, in this picture, I would specifically want to point out to certain things. You can see the molecule which is called as aggrecan. Aggrecan is essentially proteoglycans which are arranged in a brush-like. It's called as a bottle brush appearance, a bottle brush-like fashion along a core protein. The core protein is usually a hyaluronic acid chain. Usually the proteoglycans like keratin sulfate and chondroitin sulfate, they are arranged in such a way that it appears like a bottle brush. Now this aggregan molecule is essentially responsible for the biomechanical function of the cartilage. The cartilage essentially can be thought of as a cavity which is filled with, obviously it is not a cavity filled with aggregans and all those things, but functionally it can be looked of as not a cavity, but like a sponge which has basically these aggregan molecules and all in the center, and it is covered by a dome of collagen, which essentially gives the structural integrity to the whole cartilage. Now, the two factors which are affected with aging and which leads to degenerative joint diseases essentially a reduction in this aggregants. Now, what essentially happens is that if you would all know that you can basically divide the connective tissue components into two factors, basically the cellular and non-cellular. The non-cellular components essentially has basically fibrillar and non-fibrillar components. The fibrillar components are collagen and elastin. The non-fibrillar components are proteoglycans and hyaluronic acid and the ground matrix which is formed. Now, the role of aggregans is essentially to expand when it comes into contact with water molecules. Now, the water content within the cartilage is at rest without loading is seen in the superficial and in the transitional zone, and the highest presence of the aggregants is seen basically within the deep zone as well as in the transitional zone. Now, what happens is that when a force falls on the superficial zone, there is a squeezing of water from this superficial zone into the transitional zone and to the region where these aggregant molecules are in abundance. Once water is taken up by these aggregant molecules, they are like those colored jelly balls which you put in water, which expands when when you put it in water. What happens is that the adjacent sides of this bottle brush are essentially they carry a like charge. They carry a like charge in the sense adjacent sites would probably carry a negative charge. So and that charge is basically activated when water seeps into the space between these bottle brush structures. So when water seeps into the space between this bottle brush structure, what happens is that these like charges tend to repel each other, and the aggregant molecule essentially expands. And that expansion of the aggregant molecule essentially decelerates the force which falls onto the cartilage surface. Now, one of the primary changes which is seen with aging in connective tissue is that in connective tissues is essentially dehydration. One of the reasons why dehydration occurs is a reduction in the proteoglycans, which can bind to water molecules and hold that, as well as specifically in cartilage. Specifically in cartilage, what essentially happens is that the chondrocytes secrete less of the building blocks of aggregants to perform this function. That is the primary thing. The second change which essentially occurs is the change in the physical properties of collagen. Now, collagen per se is a polymer, and it can basically since like any other long chain polymer, it can essentially fold upon itself, and it can essentially form intramolecular or intermolecular bonds, and that is one of the commonest changes which is seen with aging. That is like, there is increase in cross bondage which is formed within collagen, thereby making collagen more rigid, not necessarily stronger, but it becomes stiffer. Now, and it becomes more anisotropic. Anisotropic in the sense, if you take a surface which is covered with collagen, the force bearing capability at some areas of the surface will be less, and at some areas it will be more. And that can essentially lead to a stiffer object is basically more likely to fracture than an object which is more ductile or more pliable. So, when the stiffness of collagen increases, there can be structural failures which occurs within this dome, which comprises the superficial and the transitional zone of the cartilage. Both of the changes are associated with aging, and these changes have been thought to lead to the degeneration, or like the reduction in force bearing capacity, which is apparent with aging. And if you basically consider the degenerative joint disease as a wear and tear, this is the primary factor which leads to that kind of a wear and tear, because it changes the physical properties of the cartilage. Now, essentially, we have to come. We will discuss a term which is called as chondrosenescence. Now, chondrosenescence is actually an age-dependent deterioration of the chondrocyte function. Now, chondrocytes are the cells which are there in the cartilage. Okay, the connective tissue cells which secretes the materials which are required for building the cartilage are called as chondrocytes. Now, chondrocytes essentially with aging, they tend to show something which is called as chondrosenescence. Now, essentially what it does is that the chondrocytes, aged chondrocytes, tend to express pro-inflammatory cytokines and matrix degrading enzymes over a period of time. That means, like, irrespective of an external agent causing a damage, what happens is that the chondrocytes themselves, as a part of their aging in the sense, multiple times they would have differentiated and they would have reached a state, and once they start expressing that senescence, what they will do is that along with the connective tissue components of the connective tissue matrix, they tend to express pro-inflammatory cytokines and matrix degrading enzymes. Now, these enzymes essentially will cause a breakdown. It causes proteolysis. It basically causes breakdown of the collagenous structure, which essentially holds the cartilage together. And so, technically speaking, the degeneration begins from within the cartilage itself. So it is as if the chondrocytes have been programmed to do that. Now, the question is, osteoarthritis doesn't happen in everybody. There are people who get osteoarthritis, there are people who do not get osteoarthritis. But the consensus is that probably all of us would get osteoarthritis if we live long enough. Only thing is that most of us die before we get osteoarthritis. But over a period of time, it is going to happen with these changes which happen in the way the chondrocytes behave. Now, there has been research on the role of circadian rhythm on the expression of genes, as well as how a lifestyle which essentially violates the circadian rhythm, like waking up, sleeping late, inadequate sleep or inadequate rest, etc., can basically lead to cartilage degeneration. What they have found is that the circadian rhythm plays a great role in expression of genes which are responsible for cartilage repair and maintenance. And an alteration in this circadian rhythm essentially leads to lack of expression of reparative proteins, or lack of genetic expressions which can lead to proper repair and maintenance of the cartilage, which over a period of time can lead to a cartilage degeneration and osteoarthritis. Now, the second structure which we would talk about is the subchondral bone, which essentially lies just under the cartilage. Now, in the late stage of osteoarthritis, there can be certain specific microarchitectural changes which are seen in the subchondral bone. Now, there is what happens is that the cartilage is supposed to mitigate the vertical loading which happens onto the subchondral bone. Now, when there is a degeneration of the cartilage, the subchondral bone essentially subjected to greater forces. Now, when you subject subchondral bone to greater forces, by Wolff's law, it basically responds by hypertrophying itself, which later on manifests as as the osteophytes and all. Now, what essentially happens is that these abnormal forces which fall on the subchondral bone essentially leads to osteoblastic activity, which causes increased bone volume and thickening of the subchondral bone plate, and there can also be increased trabecular thickness, and there can be decrease of trabecular separation and bone marrow spacing. And these changes essentially makes the subchondral bone from a pliable structure to a non-pliable structure. So technically speaking, the cartilage is degenerated, and the subchondral bone, which was pliable in the sense a sponge bone essentially should show less stiffness compared to a cancellous bone, compared to a cortical bone for that matter. But the changes which happen as a result of osteoarthritis essentially tends to make this bone more stiffer, and the greater the stiffness of the bone, greater will be the absorption of forces which fall onto the joint, which again triggers further degeneration. So, subchondral bone, the most common change which we observe radiologically is the subchondral sclerosis. It is basically because of the change in microarchitecture of the bone. Essentially, the bone, tends to hypertrophy under the stress which is falling on it. Like, it is similar to what would happen when you train yourself to break bricks or break hard objects with your hand or your foot when you're training for as a martial artist. What happens is that the adaptation would be in such a way as to increase the density of the bone and increase the mineralization of the bone so that it becomes capable of bearing that forces and moving through a solid object. Now, when you are actually having an osteoarthritis, you are inadvertently exposing the subchondral bone to such forces, which otherwise would not have fallen on it if there was an intact cartilage. Now, what happens is that the subchondral bone basically responds by regenerating itself, but in a disorderly fashion. That means some areas there will be greater regeneration, some areas there will be lesser regeneration, but ultimately it becomes a more stiffer bone. That's what is going to happen. Now, though there is increased bone volume, there is reduced mineralization, and the mineralization of the subchondral bone would be much lesser than even sometimes the osteoporotic joints actually. Now, the second feature which is seen in a subchondral bone in association with an osteoarthritis, and what essentially leads to the pain which you experience in osteoarthritis, is something called as bone marrow edema-like lesion. Okay, bone marrow edema-like lesion is responsible for the pain which arises out of osteoarthritis, because cartilage per se is an aneural structure. It doesn't have nociceptors embedded in it to give rise to pain. The pain which you experience as a part of osteoarthritis, technically, specifically in the initial stages, it arises out of the subchondral bone. And one of the factors which leads to this pain is basically bone marrow edema-like lesions of the subchondral bone. Now, what happens is that there is no true edema within the bone marrow, but on a radiograph, especially on an MRI, a T2 weighted MRI, it appears like there is an edema within the subchondral bone, and that's why it's called as bone marrow edema-like lesion. Now, bone marrow edema-like lesion can be present in people who are not diagnosed with an osteoarthritis also, but those people who tend to show a bone marrow edema-like lesion in an MRI without the diagnosis of an osteoarthritis, they go on to have an osteoarthritis sometimes later in life. There's a high correlation between the presence of bone marrow edema-like lesions and osteoarthritis later on in life. The third change which is seen in the subchondral bone is something called as a subchondral cyst. Now, most of us, when we would have looked at X-rays, would have seen this specific picture. We would have seen an area within the bone where there is a cavity with a hypodensity. Now, subchondral cyst is basically an appearance of a cyst-like lesion in the subchondral bone. A cyst is usually termed as a cavity which is fluid-filled, okay, which might be lined by an epithelial lining, but a subchondral cyst will not have an epithelial lining. It is just a cavity-like lesion which is there in the bone. It may or may not be filled with fluid. Now, subchondral cyst, presence of subchondral cyst on a radiograph has been associated with greater disease severity. It has been associated with greater pain and faster progression, higher chances of joint replacement. Now, how this subchondral cyst arise? There are two theories. One is intrusion of synovial fluid. Now, synovial fluid usually cannot intrude into the subchondral bone because there is a articular cartilage above it. Now, degenerated articular cartilage essentially leaves exposed areas of subchondral bone, and they can be, we'll subsequently see there's something called as micro cracks, or there can be micro fractures on the subchondral bone through which the synovial fluid is believed to intrude into the subchondral bone, and it essentially makes those cyst-like lesions in the subchondral bone. The other theory is that there is necrotizing lesion of the subchondral bone because of this abnormal force bearing or weight bearing which happens because of cartilage degeneration, and those necrotized areas of subchondral bone appear like cysts in a radiograph or in an MRI. That's the other theory regarding the development of subchondral cyst. Now, this is the appearance of a subchondral cyst per se. It's a cavity which is devoid of any bone tissue, which may or may not be filled with fluids, and it is apparent in X-rays. I couldn't find an X-ray of the same to put here, but when you look at osteoarthritis X-rays, all of us would have come across this specific areas of deficiency within the subchondral bone. Just underneath the joint surface, there will be areas where you see it looks empty on the X-ray, which essentially is denotive of this cyst. Now, there can be two kinds of micro damage to the subchondral bone also, which is called as micro cracks and diffuse micro damage. What happens is that the subchondral bone undergoes micro fractures. Now, micro cracks and micro damage are essentially same, but the location of micro cracks may span the subchondral bone as well as the calcified region of the cartilage, but micro damage is seen only within the subchondral bone. Now, the third aspect is what happens to the synovial membrane in a degenerative joint disease. Now, to put it very simply, the factors which arise out of the degeneration of the cartilage and the subchondral bone, for example, the fragments which arise out of a degenerated cartilage, essentially can go and irritate the synovial membrane. Now, synovial membrane, basically, histologically, the cells of the second layer of synovial membrane, that is the intimate layer of the synovial membrane, is essentially like fibroblasts and macrophages. And what they tend to do is they tend to phagocyte these fragments or small particles which arise out of the cartilage. And once they phagocyte this, and they essentially produce pro-inflammatory markers, and there will be localized areas of inflammation within the synovial membrane. And that is when you see a swollen joint. A swollen joint happens because of the synovial irritation, which leads to synovitis. And again, synovial membrane has its own nociceptive supply, so it essentially becomes a painful joint when this synovitis is present. Now, let us go to the symptoms of osteoarthritis. Now, we have to essentially look at it as a progressive disorder which happens over a period of time. Over a period of time, it might take months to years for a degenerative joint condition to essentially manifest itself. So, the most common symptom of an early osteoarthritic change essentially is a stiffness which is preceded by a duration of inactivity. For example, like you have been sitting somewhere without moving a limb, as in the case of traveling in a bus or a train or something, or if you have been sleeping. Now, when you get up, you tend to feel a stiffness around the joint, which can take up to 30 minutes to become completely free. Now, activity would basically reduce the stiffness, but it would take a certain amount of time for the stiffness to reduce. Now, this is the first sign which could be there even before the appearance of pain or other symptoms. This is considered to be the first symptom of a degenerative joint disease, that is stiffness with inactivity, which may take some time to subside. Now, there are the progression of the disease can clearly be mapped into 3 separate stages actually. Now, sometimes the patient might come to you, in the earliest phases of osteoarthritis. What they would complain is that they do not have pain in regular activities. They can sit in a toilet, get up from a toilet. They basically they basically can walk. There's no pain in that. They can climb a flight of stairs. There's no pain. But if they are doing some unaccustomed activity, for example, the patient on a regular basis lives in his home without any issues, but he tend to basically go with his friends for a trek or something, or he went to a pilgrimage site where there was a climb, and during those unaccustomed activity they start experiencing pain, and the pain essentially arises out of unaccustomed activity like prolonged walking, prolonged climbing, etc. Okay, that is the first level of progression of an osteoarthritis. So in unaccustomed activity, you start having pain. Okay, that may not be manifested in activities of daily living, because activities of daily living are accustomed activities. So you wouldn't feel the pain in those activities. Now, if you go for a corresponding radiographical evidence for the same, there may not be any kind of radiographic findings in this particular stage. There may not be a subchondral sclerosis. There may not be a joint space reduction. There may not be any other kind of radiological evidence at this point of time. At this stage, or the first stage, there will be no radiological signs, but rather, it's clinically manifested as a pain during unaccustomed activities. The second level of progression is where, the pain basically comes in accustomed activities or in certain activities of daily living. For example, a person finds it difficult to sit in an Indian closet and get up, or finds it difficult to sit in toilet and get up, or finds it difficult to climb stairs, etc. So accustomed activities becomes painful, but the pain is relieved by rest. In both the scenarios, the pain is relieved by rest. Now, the third level of progression is basically the pain is manifested at rest also. And this pain may lead to awakening of the patient from sleep in the night. So that is the third stage of progression. Now, in the third stage of progression, the second and third stage of progression, there will be visible radiological features in the X-ray. For example, there will be joint space reduction. There could be subchondral sclerosis. There can also be osteophyte formation. Now, the stage 3, that is a pain at rest, is usually also associated with a synovitis. A synovitis secondary to an osteoarthritis would be the reason why there would be pain in a non-weight bearing stage, because there is a lot of nociceptive sensitization occurring because of the inflammatory markers being present in the joint. That is the reason there is going to be a pain at rest, and that usually would mostly be associated with a synovitis also.
Sorry, Dr. Sham, sorry to interrupt you.
Yes,
We are running behind the time. So
I'm so sorry. I'll be winding up in another 10 minutes. Is it fine?
A little bit early.
Faster, yeah, I'll try to do that. Yeah. So the other so what are the physical examination findings which you're going to find? See, absolutely, there'll be no key physical examination findings when in the early stages, but later on there could be early osteoarthritis. The physical examination findings would be completely normal, and there could just be subtle prominence of finger joints or slight effusion of the knee on close examination might be present. Okay, as the disease progresses, there will be on palpation there will be joint tenderness, there can be warmth, and there will be limitation of range of motion in certain directions. There can be an audible or a palpable crepitation which is felt. There can be there can be development of bony prominences in the later stages, like the appearance of a Borchardt or a Hubbard's nodule in the case of osteoarthritis of hand. There can be and one of the key aspects which many people tend to miss is, or you would have always felt it, when you are actually moving an osteoarthritic joint, you feel a level of instability. What happens is that the joint cavity has reduced in size. So the ligaments and all of the structures which were stretched across the joint now essentially are facing a mechanical insufficiency. And as a result, there is going to be a joint laxity or unexpected mobility in the joint. Now, this is indicative of incompetency of the supporting ligaments of the joint. So this is an example of, so you can see basically a Hubbard's nodules in the distal IP joint, and you can see a Borchardt nodule in the proximal IP joint. These are all changes which happen to the bone when there's a degenerative joint disease. So in joint, the other factors which you would observe in physical examination are malalignment of the joint. There can be valgus or varus deformity. There can be severe limitation of joint motion as the disease progresses. The disease severity may be manifested over a period of time as osteoarthritis involving multiple joints with referred symptoms. Now, what happens is that osteoarthritis within a joint essentially leads to that joint not being capable of performing the function in the kinetic chain, which essentially puts greater stress on the other joints which are there, which essentially tends to again develop a degenerative joint disease. So, over a period of time, and an elderly, you can expect osteoarthritis being manifested in multiple joints rather than just one joint. And these osteoarthritis can also manifest with referred symptoms. So an example of a genu varum, which would usually be seen with osteoarthritis of the medial compartment of the knee, we can see that there is absolutely no joint space on the medial side. You can see this hypertrophy of the subchondral bone, which is observed as the subchondral sclerosis, the bright subchondral bone, and also you can see a lot of osteophytes on both the sides of the knee. Some of them are because of the traction which happens because of abnormal pull of the ligaments, others are because of the weight bearing which happens. So in the most common diagnostic imaging, or the most suitable diagnostic imaging for osteoarthritis, especially in the later stages, would be an X-ray, a plain radiograph. Now, a plain radiograph would basically give you idea about the cartilage. It would give idea about the bone, as well as it would give idea about the surrounding connective tissue to some extent, but not fully. But the limitation is that it may not be of any use in detecting an early osteoarthritis, because even if you go for Kellgren-Lawrence classification for OA-knee, the stage 1 osteoarthritis, there is absolutely no radiological finding. You have to basically clinically observe for symptoms. That's what has to happen. So early osteoarthritis may go undetected in basically a plain radiograph. So you can see the signs of an osteoarthritis here on the medial compartment. There is a reduction of the joint space. Again, you can see subchondral sclerosis, and you can also see an osteophyte towards the medial border of the upper end of the tibia, which essentially says is a quite advanced osteoarthritis. So the use of MRI can be used for early detection and structural differentiation. See whether the synovium is involved, whether the subchondral bone is involved, what kind of cartilage involvement is there. If you really want a structural differentiation, MRI would be the investigation of choice. Lab investigations have absolutely limited role in diagnosing or management of osteoarthritis, because it is usually used for ruling out the presence of other conditions which could potentially lead to joint pain or joint disease. Now, the American College of Rheumatology criteria for diagnosis this is American College of Rheumatology criteria for diagnosis of osteoarthritis of hand, knee, and hip actually. So you can see they have set certain criteria. See, one of them being age over 50 years, and stiffness being morning stiffness less than 30 minutes, and crepitations on motion, and osteophytes on radiograph. These are the diagnostic criteria for OA knee. And one of the key things which I want to highlight is basically the ESR less than 10 millimeters, 10 mm per hour, because what they essentially want to emphasize is that you have to rule out other kinds of inflammatory joint diseases which could actually raise the ESR, like septic arthritis or other forms of polyarthralgia. So it has to be ruled out. So ESR less than 10 mm per hour is basically one of the diagnostic criteria for diagnosing a degenerative joint disease. So prevention and management, essentially, we have seen the risk factors. Now, the modifiable risk factors are the weight and obesity, activity levels, and essentially we said that injuries which happen at some point of time in life can later on lead to a degenerative joint disease, and lifestyle modification, like I told you, circadian rhythm alterations. Okay, your the kind of food which you consume, which can lead to oxidative stress, etc., can basically lead to osteoarthritis. So the prevention of osteoarthritis essentially involves trying to modify this modifiable risk factor. Out of this, one of the most commonest things which we would be actually endorsing would be the loss of weight or management of obesity. And also what we also have a role to play in activity limitation and injury prevention, activity levels and injury prevention. Essentially, we need to promote an increased level of physical activity in the early ages of senescence, so that it prevents development of, or even the increased physical activity has to start at the earliest, and early initiation of increased physical activity basically reduces the prevalence of degenerative joint diseases later on in life. Injury prevention essentially happens through to people who are vulnerable for injury, for example sportsmen or athletes. We need to essentially adopt strategies for injury prevention, probably like we may have to modify the risk-taking behaviors. We may have to essentially improve the kinetic control of the joints to essentially prevent injury from happening, strengthening or other kinds of neuromuscular training which can prevent injury from happening. Okay, and lifestyle modification essentially following a healthy diet and lifestyle, including proper sleep hygiene. So, you know, basically I'll skip to the secondary prevention. That is, once the osteoarthritis has occurred, what has to be done? Now, you know, we basically can divide the management into three aspects, that is remedial, compensatory, and finally something called as environmental modification. Now, remedial management would be something which is aimed at, like, you know, arresting the progression of the pathology as well as reversing the changes which has happened. Now, you know, and compensatory management is essentially, like, you know, accept the loss which has occurred and, like, you know, compensate for that loss with either intrinsic or extrinsic compensation. And environmental modification is basically when both remedial and compensatory management is inadequate and the person is not able to interact with the environment in ways, like, you know, which are normal for his age and gender. Okay, then you need to modify the properties of the environment in such a way that the interaction of the person with the environment becomes easier. Now, the role of a physiotherapist from the perspective of remedial management, that is to arrest the progression of pathology, would be to attenuate the transmission of forces through the joint. Now, this essentially can be done by improving the muscle function as well as the neuromuscular coordination across joints. So, you know, exercises which are aimed at improving the muscle performance, variables like strength, endurance, in various type of muscle work, eccentric as well as concentric as well as isometric, as well as the coordinated muscle activity of synergists, antagonists, and agonists across a joint, which essentially will lead to joint protection functions need to be initiated. Now, you know, we also have a role to play in management of symptoms, albeit with very, like, you know, conflicting evidence. Though these are practiced by physiotherapists, may not be recommended by guidelines, like the application of heat or cold, electrophysical agents like, you know, TENS or other kinds of pain relieving modalities, and manual therapy. Though, like, you know, there is a conflicting evidence regarding the use of manual therapy in clinical settings and individual, like, you know, from an anecdotal evidence point of view, manual therapy essentially is a very useful therapeutic intervention which can be given to reduce pain as well as to improve the range of motion and functioning of the person with osteoarthritis. Now, you know, an integrated program which emphasizes on exercise would be the most appropriate treatment to be given to a person with osteoarthritis. Now, here is basically, like, you know, a comparison of the various guidelines for management of osteoarthritis. This is from 2019. Now, you know, the most strongly recommended variables across all the guidelines is weight loss or, like, you know, weight reduction. Now, three of the guidelines basically are strongly recommended. One, there is a moderate recommendation for weight reduction, and the next one is essentially exercise. Now, you know, whether it has to be an open kinetic chain, whether it has to be a closed kinetic chain, what kind of exercise, whether it's land-based, water-based, etc. There's a myriad of articles which are available on recommendation of exercises, but exercise is commonly recommended for the management of osteoarthritis, and it has to be personalized. That is the basic, like, you know, that is the basic message which has to be put across. Biomechanical interventions or biomechanical corrections have been basically recommended by some guidelines. Biomechanical corrections is essentially trying to change. No, weight loss is essentially a biomechanical correction. You are reducing the reaction forces which are developed in the joint. Now, you know, you can also alter the direction of force transmission through a joint. For example, like, you know, by using a knee unloader. This is an osteoarthritic knee brace, which essentially can apply a varus or a valgus stress. There is no great evidence for the use of it. And one of the reasons why there is no great evidence is the adherence to this device has been found to be poor. But it is believed to basically relieve the joint compressive forces acting upon either medial or lateral compartment of the knee by applying a valgus or a varus stress along with a traction. Now, similarly, you know, one of the most common biomechanical correction which we adopt is essentially to put a lateral wedge for medial compartment osteoarthritis. So if you put a lateral wedge on the footwear, it essentially pronates the foot. Now, pronation of the foot will lead to a tibial internal rotation, which will essentially lead to a valgum at the knee. So, you know, you are trying to essentially create a valgus stress at the knee when it is actually going into a genuine varum per se. So, these are like, the other recommendations for the management of osteoarthritis. Some guidelines recommend this, some do not recommend like biomechanical corrections as strongly. Now, when everything else fails, and you want to rehabilitate the person, now obviously corrective surgery is ultimately like the answer for a degenerative joint disease. Okay, along even pharmacological management, it has its own limitation, but surgical replacement of the joint would be like wherever permissible would be like the appropriate management. Some patients may not be indicated for a surgical management, but still you would want to reintegrate them back to the community. What you need to do is you essentially need to change the properties of the environment. So environmental modification becomes the last stop for basically promoting activity in people with osteoarthritis or degenerative joint disease. So these are examples of modifications which can be done where you tend to minimize the environmental modification. The basic principle is you reduce the number of degrees of freedom which needs to be executed to do a task, as well as you reduce the amount of force production which needs to be there for executing a task. So those are the basic guiding principles behind environmental modification. So the environment is basically involves everything which you interact with other than your body. So it can be your buttons, or it can be your utensils for eating, anything. So environmental modifications appropriate to the patient, specifically for the kind of functions which the patient has, and to use the patient's existing function to like enhance or executing other kinds of tasks. That's what you'll have to do in environmental modification. So change the property of the things that the person has to interact with appropriately, not like blatantly. So that is it. I'm so sorry I had to rush through it, but like that brings an end to the talk per se.
Thank you very much, Dr. Sam, for this indeed and a very good explanation about OA knee happen, how it happens and all. So it was a very good presentation, and I hope all the participants must have understood it in very nice manner. There are a couple of questions which participants would like to know, sir.
Yes, madam.
Yes. I will just one participant Lima is asking, most commonly seen post-arthritic procedure, individuals are prone to get knee degeneration after a decade. Would you like to know would you like to explain the pathological cause of the same?
No, madam. What is it actually? I didn't get the question.
Most commonly seen post-arthroscopic procedure, individuals are prone to get knee degeneration after a decade.
Yeah.
They wanted to know the pathological cause behind it.
Okay.
Can you just explain in short, because we
Absolutely.
are running behind the time a lot.
Absolutely. I'll just explain in short. See, one of the strongest predictors for developing a degenerative joint disease is actually at any stage in your life having a prolonged inflammation within the joint. So, a surgical procedure, whether it's arthroscopic or not, essentially leads to inflammatory changes within the joint, because, healing has to happen with inflammation. So, whether it's an arthroscopic procedure with minimally invasive surgery, that also essentially could lead to an inflammatory state being developed inside the joint for a prolonged period of time. Now, these inflammatory mediators have been shown to essentially trigger the changes which occur in cartilage and the associated structures, which can lead to the osteoarthritis later on in life. So, the presence of a prolonged inflammation, now 10 years later means your age has also advanced. That many years your bone weight also on the joint, that essentially plays a complex interaction of variables which will lead to osteoarthritis later in life. So the primary reason is the post inflammation which is there. Yes.
Thank you, sir. One more question by Mr. Vijay. Is that any correlation between quadriceps inhibition, knee osteoarthritis, and knee ligament injuries?
See, obviously, like if there's a quadriceps inhibition, see, the thing is, I really don't get in which context you're talking about. There is a relationship between quadriceps strength, quadriceps weakness, and osteoarthritis of knee. Now, I told you quadriceps weakness is both a causative factor as well as a consequence of osteoarthritis of knee. A person who is having an osteoarthritis knee will have progressive weakening of quadriceps, as well as a person who has weak quadriceps will develop a osteoarthritis knee at some point of time. Now, the thing is that now, when you're talking about especially tibiofemoral joint, as a rigid liver, when the lower extremity has to bear weight, as in the case of mid stance, for example, it's in a 5-degree flex state and it is bearing weight. In these scenarios, you essentially need to have a very strong quadriceps muscle to actually to provide the control, the necessary control, neuromuscular control of the joint, so that there is no abnormal mobility happening, which can jeopardize the integrity of other structures like ligaments. And for example, you are wearing weight and suddenly your quadriceps gives way, you are going to have a sudden post flexion. It could potentially damage the ligaments within the knee. So that way, when you look at it, quadriceps function is essential. In case of knee, it is essential in so many ways, and quadriceps function is not just essential for the knee, it is also essential for the normal functioning of the hip joint in weight bearing positions, because it essentially connects the intermediate joint, that is the knee joint. There's an ankle joint, there's a hip joint within the kinetic chain, and this is the strongest rigid extensor of the intermediate joint, and its function is absolutely necessary the way the hip as well as the ankle functions too. So that way, yes, it can lead to a ligament injury probably,
Yes. So one more question.
Yes,
from Ms. Richa. Does micro damage or micro tear of articular cartilage recover with strengthening of leg muscles and prevent early ONE?
See, one of the things with chondrocytes is that under any circumstance, chondrocytes are very sparse in number. Unlike other connective tissue cells, chondrocytes are actually very sparse in number. Now, you would have learned chondrocytes basically work in a low oxygen environment, and when they are stressed in the low oxygen environment, they secrete this connective tissue matrix, that is, the proteoglycans and the fibrillar matrix. That's what they do. Now, once the chondrocyte function is attenuated to a certain level, starting to produce inflammatory markers, not secreting adequate aggregates, etc., and there is a loss of chondrocytes as you age, then there is no chance of recovery occurring, because this have to essentially arise out of the chondrocytes itself. If there is reduced chondrocyte function, there is no scope of these things being produced. But that being said, there is a surgical procedure where you create microfractures on the subchondral bone, which bleeds, and the hematoma which is formed becomes a cartilage. That is a cartilage formation occurs from the hematoma. So that is done in osteoarthritic knee joint. It's a surgical procedure. Now, what happens is that again there will be fibroblasts within that hematoma. That hematoma, there will be fibroblasts, which when actually is pressurized, fibroblasts are essentially pluripotent cells. They can basically become an osteoblast or a chondroblast depending upon the kind of environment they are put. So when they are pressurized under normal circumstances, they basically tend to transform the hematoma into a cartilage kind of. That is what I believe happens in fact. So otherwise, no, there is no chance this can spontaneously recover with exercise or any other kind of. I don't think it would actually, though we may like to believe that.
Thank you so much, Dr. Shyam Krishnan, for this wonderful presentation and nice question and answer session. Thank you so much, and I thank Dr. Chandramohan sir also for inviting me for this chairing this session. Thank you so much.
Yes, madam. I would like to take opportunity to thank Vijay Kumar sir. By him only I came to know. I take this opportunity to thank him. Thank you, Shyam sir. Thank you, madam.
Thank you very much, sir. Thank you very much for this opportunity. Thank you, ma'am. Thank you for moderating the session. Thank you. Thanks a lot.
Thank you, sir. Thank you, ma'am.
Thank you.
Kindly check with
With
Ajim.
all respect and gratitude,
Yes, Azim sir is here.
I take this opportunity to
Continue, madam. Arunima, madam.
with all respect and gratitude, I take this opportunity to introduce a chairperson, Dr. Annie Thomas, Garden City University, Bangalore, India. We are so privileged to have you here, madam, to grace this event and host the session with our resource person, Dr. Ajim Shah. Over to you, ma'am.
Thank you, Ms. Arunima. I am audible, Chandramohan?
Yes, madam. Very much audible, madam.
Okay.
Annie, ma'am.
Thank you, Arunima. I would like to introduce the renowned speaker for the next session, Dr. Ajim Shah. So, Dr. Ajim Shah is an enthusiastic physiotherapy research specialist from Qatar. He is well known as a clinical expert, professional leader, academician, and researcher on fascia science, neurorehabilitation, and critical care. He is also working as the consultant of program of physiotherapy in Cartilage University and advisory panel member of World Fascia Congress. Following his postgraduate degree in neurophysiotherapy and master's in healthcare, he has obtained consecutive doctoral degrees in neurorehabilitation, facial science, and in osteopathy from India, UK, and Spain, respectively. He has 15 years of experience in academic and clinical fields across the globe, having more than 30 high-indexed journal publications and almost double the number of conference proceedings. Under his name, with H-index 8, he's a key person in the Department of Physiotherapy, working in corporate level as a strategic planning committee member, head of research committee, quality improvement programmer, recruitment committee member, etc., and led the transformation of stroke rehabilitation of Qatar, chronic pelvic pain management, and standardization of the management of spine rehabilitation. He was also the lead of COVID-19 acute care physiotherapy best practices task force in Pathar, which has been published recently with high number of download across the globe. Dr. Ajim Shah has received various international awards for his contributions to fascia-oriented research and neurorehabilitation. He was the opening keynote speaker for the recent World Fascia Congress, SARS-CoV-2 Rehab Conference, Qatar International Geriatric Conference, and Middle East Forum for Quality Care. We wish Dr. Ajim Shah all the very best in his future endeavors, and I am glad to welcome you for the next topic, that is critical and acute geriatric care. Welcome you, sir. Over to you.
Thank you. I think I'm audible. It's been a bit long waiting, actually, but it was like a very heavy duty ultra pathologic presentations too, from Mr. Yasser sir and Dr. Shyam. So back to area, what I'm going to do is actually going to present something different from what we have heard so far. Let me open it. Okay, so I'll be presenting something on how the critical and acute care is facilitated or altered or modified to include the geriatric care in a physiotherapy perspective. So since the time is constrained, I'll be moving a bit faster, and maybe we can later go for a Q&A session. Globally, people are living longer, you know that. And by 2050, older people will account for 1 in 6 people, approximately 16% of the global population. Older adults make up on 1/3 of acute hospitalizations and half of all hospital stays. And for them, hospital admission is a significant risk factor for loss of independence. Functional decline is the leading complication of hospitalization. In order to people to at least 34% of older patients lose independence with at least one ADL activity affected during their hospital stay. All these contribute to the so-called hospital-associated disability. You can feed this word. This is the most common word we use in the acute or critical geriatric care, HAD, hospital-associated disability, which is the inability to ambulate, prolonged hospitalization, higher healthcare expenditures, and increased requirement for institutionalization after discharge. Hospitalization can result in rapid deconditioning, overall weakness, and functional decline, which is related to a substantial loss up to 10% of total leg mass, lean leg mass, which we used to call, as little as within 7 days of hospital inactivity. And the current hospital practices, we know that, promotes immobility and bed rest, reliance on others to basic ADLs such as toileting, hygiene, and feeding, a system that is intrinsically harmful for older adults because already they are having less physiological reserve. Early mobilization programs are important interventions that have been shown to reduce patient disability caused by the hospitalization, and it often reduces the length of stay while the way it helps to reduce the cost of the care. Frail patients or weak patients are often discharged with a new major disability. A patient may be admitted because of pneumonia. Pneumonia will be resolved. After that, the patient need a walker for walking. More than half of all the older adults do not recover to their pre-admission functional levels 1 year after discharge, according to meta-analysis. The new models include exercise, especially strengthening exercise, as an essential part of conventional treatment. Simple and basic procedures, such as increasing the walking duration by at least 12 minutes or daily slow walking, can even reduce the average hospital stay. Multi-component programs, balance, strength, agility, all sort of things, and especially resistance exercise that include muscle power training, are currently the most relevant interventions to slow down disability and other adverse outcomes. So, hospital-acquired disability is a major problem. It always manifests as a loss of ability to complete one or more of these basic ideals needed to live independently. And tethering medical devices such as intravascular lines, central lines, oxygen tubings, catheters, and all sorts of things actually makes the life more vulnerable. The special emphasis on catheter, urinary catheter, which the studies are showing that increases the length of stay, morbidity, and even mortality. Okay, so what is the recommendation is, except in critical situations, urinary catheters are rarely required to keep the track of urine output. Normally, whenever there is a patient admitted, customarily they will first put in is the urinary catheter. And to go into the critical, the two terms are very significant. One is frailty, another is sarcopenia, and which in acute care we always used to say these words. The term frailty or being frail is often used to describe a particular state of health, often experienced by older people as weak. Common features of frail health in older people include decreased capacity in bodily functions, leading to increased vulnerability in the event of acute illness or psychosocial trauma. Around 10% of people aged over 65 live with a frailty. So when every 10 that means decades goes, the percentage increases. This figure rises between 25% to 50% for those aged over 85 years. So this can be a general weakness. You can see the deficit accumulation, fatigue, sedentary behavior, weight loss, cognitive impairment, social isolation, weak muscle strength, slow gait speed, poor balance, or sort of things. 3 to 5% of death in older adults could be delayed if frailty had been prevented based on comprehensive assessment or CGA, which I think was the first topic of this day. And that is a gold standard of geriatric assessment in acute care. Sarcopenia is another term which uses to mention the low muscle strength with the low muscle quantity or quality. Both are huge subjects out of this 25 minutes or 30 minutes presentation. So sarcopenia, you will lose your muscle mass, which causes morbidity. Frailty, you will get weak as the age, the physiological reserve reduces, which causes the functional dysfunctional syndrome. Sorry, function dysfunctional syndrome. So to understand that one, how the frailty goes, when you are old and active, you are still using the physiological reserves, what you have left in your body. But when you are already weak and frail, you are already using the physiological reserve, so that any acute event like hospital admissions or a fracture or a pneumonia, something like that, causes vulnerable situations or tapping of the already exhausted physiological reserve. Let's say that you have admitted in a hospital for pneumonia and it is being treated and it is resolved. And what will happen? You have to admit in the hospital. In the hospital, you are under immobility. You are not allowed to move. You are in the bed. You have sensory deprivation. You have malnutrition because you won't like the hospital foods. It will be, different situation. there are a lot of barriers like IV lines and all sort of things. And of course, iatrogenic complications and the environment. All this actually causes dependence and losing the what is called lip dependence and immobility, causing life going in a different way. Okay. Several programs that increase mobility in inpatients have been developed across the world. So when you're considering acute care, there are many programs that are successfully running. These words, you can keep it. And those who are postgraduates and PhD scholars, these are very new and brilliant areas to study in your area on hospital or something. So what are the programs which are very proven to reduce length of stay and reduce the frailty, even reverse the sarcopenia, are acute care of the elderly, or called ACE units, CGA, which already you have come across, enhanced recovery after surgery, ERAS program, mobilization of vulnerable elders, or MOVE program, hospital elder life program, or health programs. Okay, so identification of frail patients to eliminate heart risk is one of the main component of any acute hospital scenarios. Although our bed rest is now prescribed infrequently among inpatients, but in India, there are certain hospitals still supporting the bed mobility. Its use remains pervasive and has consequences that are still very real. A study of admitted older adults who were walking independently before hospitalization reported that they spent 83% of their hospital stay lying in bed, and only 3% standing or walking, and 14% of the time they are sitting. Not surprisingly, nearly 20% of older adults who were previously able to self-mobilize or walk were no longer able to walk without an assistance at discharge from these medical acute care units. Okay, so the harms associated with hospitalization always very critical. There are many compelling reasons to avoid bed rest. We used to call our hospital project is called Bed Rest is Bad. This is actually from we are taken from Johns Hopkins University Hospital. Bed rest results in inferior outcomes and was of no benefit if any medical condition is prevailing. For example, if you are having pneumonia, it doesn't mean that you have to be bed rest to recover fully from the pneumonia. Many complications of bed rest occur and can be significantly deleterious, as in the picture, including loss of muscle mass, increased fall risk, loss of functional independence, atelectasis, pneumonia, pressure ulcers, prolonged hospital stay, venous thromboembolism, delirium, and so on, so on, so on. So let's say louder, bed rest is bad, really bad. So when we are thinking about the muscle weakness, healthy, well-nourished individuals, even ourselves, if we are healthy, who are immobilized show signs of skeletal muscle atrophy within 72 hours, if you are in the bed. Older adults exhibit greater loss of muscle mass and the functional strength compared to the younger adults, and immobility disproportionately affects the lower limbs. This can result in a new walking dependence because hip flexor strength is required to initiate sit to stand of ambulation, and the quadricep strength is required to stand upright from a bent knee stance. Failure of these mechanisms puts individuals at a high risk of falling. So everything is connected and we are losing our independence. After only 10 days of rest, a healthy elderly person can lose 20 to 40% of their VO2 max and muscle strength in the lower extremities. A decline in pre-admission functional mobility can occur after only 2 days of hospital. So even 2 days of hospital admission with a patient or an older person is in the bed can cause decline in its functional mobility. Telling about the respiratory, there are many things, but most common I'll be highlighting. Atelectasis is a consequence of immobility that increases risk of hypoxemia and pneumonia. The supine position negatively affects breathing mechanics by reducing functional residual capacity, or FRC. Reclining causes the diaphragm to move cephalad and decreases the thoracic volume. Something called closed volume or closing volume is the volume left in the lung at the point of expiration, at which the smallest airways, the bronchioles, begin collapsing, increases as a normal consequences of aging. By the mid-40s, closing volume will exceed functional residual capacity in the supine position and result in minor degrees of atelectasis. So supine position itself is deleterious even after 40 years. Really? In elder patients, closing volume has substantially encroached the functional residual capacity, making them specially vulnerable to atelectasis from time spent in the supine position. You can see 2 days of ICU, we can see the chest is so bad, there is collapse. That's all because of these pathological changes. To restore FRC, an upright position is needed. Okay, so somebody is saying that in-center spirometry will prevent collapse or reopen the collapsed areas. To be honest, there is no evidence to support substantial evidences of atelectasis correction by means of this one. Okay, but keeping upright or early mobilization has. And hemodynamics, I'm just telling about what is the hemodynamic changes concerned with orthostatic hypotension, because for us, we do early mobilization as the prime, and these are the things hindering. Age is associated with the functional decline in homeostatic regulations or breakdown of vital cellular process. For example, bed rest impairs the carotid cardiac baroreflexes and can worsen the cause of orthostatic hypotension. This can lead to a syncope or pre-syncope upon the first attempt at ambulation after bed rest. So when we are making the patient stand, patient faints. Prolonged bed rest also causes diuresis and natriuresis, resulting in reduced cardiac filling and stroke volume, thereby exacerbating postural hypotension. Personal experience is that a common response to a patient experiencing pre-syncope when standing after immobilization is to put the patient back to bed. We put the back, okay, then say we'll come tomorrow, creating a self-perpetuating cycle. The age-related changes in detail are out of scope of this presentation, and we're already running late. And I'll be just mentioning different groups. So those who are research scholars can work and research more on this type of acute care groups. First is actually acute care of the elderly or ACE units. All this actually uses early mobilization as the tool. Comprehensive geriatric assessment and early mobilization. And all this having very strong evidences to say that it reduces the length of stay, it reduces the frailty, it reduces the post-admission complications, and so forth. Okay. The next one is CGA, which I'm going to skip because you had a very, very detailed presentation in the morning. And the CGA, what is the physiotherapist role is actually we will be the one assessing the functional status, activities of daily living, gait speed, fall, balance, even hand grip sometimes. And another program is Enhanced Recovery After Surgery, otherwise called ERAS. ERAS contains 22 evidence-based interventions for the pre, intra, and post-operative period that have been protocolized or to produce it in a best way. These interventions include avoidance of prolonged fasting, adequate multimodal analgesia, adequate nutrition, early post-operative mobilization, that is within 24 hours, okay? With encouragement of patient and family participation for 3 times daily. Our mobilizations are 3 times daily. Okay, I'll show you that. And the hospital mobilization of vulnerable elders is another program. This actually contains 3 components. Patients are mobilized at least 3 times per day. Mobilization is in the first 24 hours. Mobilization is progressive and scaled. I will tell you what is mobilization is progressive and scaled on the way of presentation. And another is HELP program. This HELP program is actually initiated to prevent delirium. The patient in ICU and all always develop delirium. It's a confusional state where the patient starts talking in different way, getting aggressive and all sort of things. And the HELP program, otherwise it's called So Sad program. Okay, so it is like simple mnemonic: sit out of bed, orient yourself, see and hear, sleep hygiene, activities, and drinks. So all again also the most part of this program is early mobilization and therapeutic activities, and sleep hygiene and the reduction of lines and vision, checking vision, hearing, keep everything positive is another factor, but it is like an healthy and friendly atmosphere. That is what is this program is called, HELP program. And another is OPAC. OPAC is giving more importance like the HELP to the delirium, but all these programs are actually based on the early mobilization of the critical and acute care patients. And it shows that more than 50% of decrease in number of falls and reduced length of stay and a lot of high amount of cost savings as far as the healthcare cost is concerned. And evidence of early mobilization to decrease length of hospital and improve outcomes are huge. We need another 2 hours to express about the evidences. There are a lot of evidences regarding the length of stay reduction, decrease incidence of delirium, fall, increased rate of discharge to home, length of stay difference, and healthy reduction, reducing the functional declines, and so on, so on, so on. So early mobilization is our food in acute care. Early mobilization is the main thing what we are managing here. And in Hamad General Hospital, we are having the Hamad General Hospital is acute care hospital in our Qatar, and any patient will be referred for comprehensive geriatric assessment upon, and the physiotherapist will be undertaking the functional part of the CGA, and we practices EM, early mobilization. EM is early mobilization intensely. You might have seen these news clips. It has get so viral even in India, if I am not wrong. And here we mobilize the patient so often, so vigorously, so intensely. He never allows them to sit or in the bed in the daytime. So in the daytime, most of the time they spend on the chair, or they will be out of bed or doing some activities. So our logos are bed rest is bad and everybody moves. So even it is intubated patient or tracheostomized patient, or a patient who is very critically ill, we mobilize them. Even the patients who is in the ECMO, extracorporeal membrane oxygenator, when the patient is having pneumonia. In the COVID time, we had a lot of ECMO patients, but we mobilize everybody so often, and we know how much it is having the advantage. And we make the patient as much as possible to vertical. We are having different robotic devices like Sarah and all sort of things which we use to make the patient as vertical as possible, as early as possible. And of course, you can see this is something around 90 years old, but we never allow them to be in the bed. We mobilize them and we put them in the social integration. Always the family, the healthcare system, everybody comes and stay with them, so that, the acute geriatric system will be. So actually what we are practicing is a combination of all the SAs, HELP and CGA system, but using in a very protocoled way. And for example, if a patient comes in the ER, and geriatric patient who comes in the ER or acute care, so there will be an initial geriatric screening, okay? And to find out the patient is critical or non-critical. If the patient is in the critical, the patient will go through the critical pathway to ICU or whatever the scenario is, where the patient will be referred for physiotherapy. We start early mobilization. The policy is start early mobilization within 24 hours of admission. So we start early mobilization within 24 hours of admission. And if the patient is not a critical one, we do the comprehensive geriatric assessment, and the patient will be screened into two categories, ambulatory or non-ambulatory. If it is ambulatory, we go for early mobilization, high intensity. So I'll show you the exercise under that one. If it is non-ambulatory type, for example, already bedridden or maximum in the wheelchair sitting, we'll go for early mobilization, low to moderate intensity. And once that one, day 1, day 2, day 3, day 4, the patient will be discharged. We'll do again a CGA at discharge, and we do a follow-up. That is our specialty. We do a follow-up assessment at 1 month and 3 months. Okay, and because we are having many studies going on, we are having many what is called RCTs, multi-center RCTs going on in our center. So we are having everything connected in a scientific way. So when we are telling about the outcome measures, what we use in acute care, the most prevalent one is short physical performance battery. So this is actually a combination of standing balance testing, sit to stand testing, and gait velocity. Okay, and then we will be using functional independent measure, which is a mandatory assessment here in our things. Then functional ambulation category, this is a short ambulatory category, like non-ambulatory, ambulatory with assistance, independent ambulation. So that is functional ambulation category. Of course, MMSE to know whether the patient is having any cognitive issues. Then we are having a lot of other outcome measures which are now beyond the scope because the time is kicking, and I'm also having, you know, like excused out of with my time. And when you are telling about this one, you should know about acute care and frailty. You should know about the clinical frailty scale. So clinical frailty scale is actually a scale which is having 1 to 9, and 1 is very fit and 9 is terminally ill. So where anybody who is the category comes more than 4, we used to say that they are frail, and we will give our intense 3 times physiotherapy or functional mobility session. We never call it as a physiotherapy session, we call it as an early mobility EM session, because not only physiotherapist, nurse, occupational therapist, even respiratory therapist, all will be joining together, but we will be leading the program. And another one is actually you have to just have a look on is that Freud's phenotype on frailty. So it is having 5 subspecialties, phenotypes. It is a weight loss. So for example, progressive weight loss of more than 10 lbs or 4.5 kgs, or weakness using by measuring the hand grip, reduced energy or endurance, slowness, and low physical activity. So if all these things, out of 5 things, 3 are positive, we used to categorize this patient as frail. If 2 out of 5 is called we call it as pre-frail. And in our country, because of, you know, like people eats a lot of sweets and all, because of diabetes and obesity and all, we are having frailty and pre-frailty comes in early rate. So we never think about the age. Anybody after 50, we start screening for frailty and associated complications. And I think this is another scale, as I mentioned, the short physical performance battery. So it is having a balance test, it is having gait speed test, and it is having chair stand test. Altogether, it is 12 is the score. And when we say that it's a 12, anything less than 10, we used to call it as they are frail. So out of 12, if one person is scoring 12, see, there is age-based differences are there, but even that one, if somebody is scoring less than 10, we used to call it as this person is showing the signs of frailty. Okay, so we will take into consideration and we'll put the patient for high intense early mobilization practice. And I'm just kicking all these things. Psychometrics, we always go for normal values and MCDs and MDCs and MCIDs to define our, this is a 10-meter walk test, this is dynamic gait index, this is 6-minute walk test, and this is 5 times sit to stand test and timed up and go test. These are the main tests we execute in our CGA, comprehensive geriatric assessment, as the physiotherapy part. And range of motion and grip strength. Grip strength is one of the most important thing we do. Why we do is actually, this actually declines, and this is an indicator of mortality and frailty. Also, there are certain studies actually noted that significantly lower grip strength among older Americans who reportedly physical limitations, including standing from a chair, walking, climbing steps, and going on. So it not only indicates the general weakness, it also indicates the walking. In 6 studies identifying walking as slow, more than 0.8 meter per second time this takes, grip strength threshold for men ranged from 23 and female it is 15. That means it is a biomarker, or it's a biomarker of aging. So hand grip is one of the must thing we used to assess for our acute care practice. And these are our practice. These are our intervention for the frail patient who is ambulatory. So it's actually contains a lot of resistance training, because persistent training is shown to be very effective in the recent studies. So we calculates the 1 repetition maximum of leg press, chest press, and every resistance training. Then we starts with the 30% of the 1 repetition maximum as the program. You can see day 1, day 2, day 3, day 4, day 5. It goes like rises from a chair, leg press, chest press, leg extension, tandem standing, tandem walking, stair climbing, walking over objects, stepping over forward, stepping over lateral, balance. So it goes up to the discharge, then even up to the follow-up, we'll do the reassessment. So this is the morning session actually, and this is the evening session. So evening session, seated leg extension, standing leg flexion, standing hip abduction. So it will be 3 sessions: strength training and balance and coordination training and evening training. Most of the evening training will be done by the patient family or the nurse of the patient. Okay, and I'll be just showing some videos that will be of interest for you. Let's say it will be working. So this is an old lady. She's doing sit to stand training in the morning session. Okay, we do assist the patient, and leg press, or we calculate the 1 repetition maximum first. Then we go starts with the 30% of the repetition maximum. So many of the family used to ask whether it will break the leg and all. No, it won't actually. That is why we are doing the comprehensive geriatric assessment and the chest press. Okay, so all this comes in the morning session, and where the patient will be brought back to our gymnasium, and they will be doing exercise. If they need oxygen, we do the supply the oxygen also. So, but we may make sure that the lower extremity muscles and upper muscles are strengthened. More emphasis is being given to the lower extremity, because that is the study showing that lower extremity exercise with the agility training reduces the falls to a significant level. Okay, so let me go to the next slide. This is the morning session. This is the second session. This is the balance and gait training, where you will be closely with the patient. And as I have shown, it should be everything is progressing. Starts from the simple, then it is improving, progressing. Initially, the therapist will be hold the patient, but later as the days improves. Maybe the patient will stay for 3 days, maybe the patient will stay for 5 days, but we will never allows the patient to be in the bed for longer period, especially in the daytime. Okay, and at night time, actually, the patient will be allowed for a sleep by rearranging the turning and everything's there. Okay, so all sort of things will be done for the balance and coordination training. All the 3 systems will be tested, vestibular, okay, sensory, all the 3 systems will be tested for the patients during the balance and coordination. And the next one is actually the 3rd session, evening session. This will be done by the nurse, because this will be done on the bedside. So be more weighted exercise. They will be applied a weight, and it will be they'll be doing hip, knee extension, hip abduction, knee flexion, all sort of things under the supervision of the family member or with the supervision of the exercise. All these programs will be having a walking. Our calculation is the walking should be minimum of 15 minutes per day altogether. So we roughly calculates that we makes almost around walking around 33 to 40 minutes of all our therapy. So we are quite happy with our calculations, and we always do the early mobilization with the higher levels of things. But always early mobilization is having a lot of issues, because it's a multidisciplinary, multi-component. There are a lot of issues. One is staff attitude. You have to mobilize the patient so often, so frequent, and the patient always telling some, excuses to escape from that one. And staff believes, the nurse believes that, oh, it's always difficult. Let the patient be on the bed. So it is the physiotherapist who goes and always talk. No, don't allow that. If the patient may go 12% of the muscle mass within the next 4 days or 5 days. So we used to say all sort of things and motivate the whole team. The lack of knowledge and training. For example, somebody is afraid. The patient is in the intubated, multiple things. We used to do the sedation vacation. We start the patient sitting edge of the bed, or we mobilize into SARA. A lot of things we do, but new staff may have an issues. Then sedation practices. Many of the hospital, they put the sedation high for 2 to 3 days. Here, we reduce the sedation. We often starts with the sedation vacation as early as possible once the hemodynamical stability attains. So always it's a big topic of discuss, early mobilization and barriers of early mobilization. And in what we exactly do here for to reduce the hospital acquired, one of the quality indicator is this one. Okay, the reduction of hospital associated disability. So this starts with a comprehensive So actually, I told you we are using a cocktail model where ACE, ERAS, help and move, all things comes together. But we start with a comprehensive geriatric assessment. Then we always go for medication review. Some of the medication causes dizziness when the patient starts. So we go for that to reduce that and we modify that. And already the doctors know that because all the patients are always out of the bed, they know what medication they have to give. Then early and frequent mobilization. Early means within 24 hours, frequent means 3 times a day. Is less use of tethering medical devices. We makes the patient free as much as possible. This has a lot of psychological support and confidence for the patient. Even the patient, when he's out of bed, patient is very confident, patient laughs. And we have very nice gardens around our hospital. We take the patient, even critically ill, with the ventilator, with the occupational therapist, respiratory therapist, with the nurse and with the doctor. We take the patient in the Sarah convalescer and take the patient to the garden. At least the view of the plants and trees and all makes them a lot of psychologically happy, and the recovery is very faster. And we do a lot of education to the family, to the patient, to the nurses and all sort of things. And we always ensure that the TID, 3 times day mobilization, goes all well. And nutrition, always our nutritionists take care of the nutrition, because nutrition, if you are going the literature, you can find that nutrition is the biggest factor of muscle mass loss during the hospital admission. So nutrition, we ensure analgesia and bowel care. We train earlier, correct sensory deprivation. So we make sure that they are having sleep hygiene, they are having a day model, and there is not much sensory disturbances during their stay there, and encourage to continue regular activities as much. So what they have done in the home before the admission, we always encourage when we are not there. So this is the things I have already, this time is kicking out. So I'm just reducing out my presentation. So there are a lot of studies already saying that, physical activity improves by early mobilization during the acute or critical care. There is length of stay reduces during the early mobility patients or groups and in the acute and critical care. And even we have found that odd ratios of mobilized developing complications are very less. So actually there are less complications in the mobilized group compared to the non-mobilized group. And muscle isometric strength, maximal dynamic strength, peak of power, all has been shown positive changes during the early mobilization compared to the or conventional or not mobilized group. Even you can see the muscle power values and the submaximal and maximal loads by group changes when you are putting the patient on mobilized and non-mobilized group. So resistance training, we give a lot of emphasis on resistance training. Actually, that is the plus point of our early mobilization, so that the patients, we believe that many of the patient actually improves more than what there comes actually, because of the frailty, especially the patients the age of 70s to 80s, we believe that our mobilization helps them a lot. So you know that loss of strength and endurance balance 10% every decades, and the muscle power 30% per decades. So we need resistance training to improve their muscle power, muscle quantity, muscle quality, to reduce the sarcopenia, to improve the frailty and reduce the functional decline, age-related functional decline. So how to conclude this one? Let me see the time. Hospital environment, critical care and acute care in its current state is harmful to older adults by promoting functional decline and dependence. High-risk patients need to be identified early with frailty screening and be approached differently by the care team. Targeting key deficits, namely cognition, nutrition, sensory input, sleep hygiene, and mobilization, showed improvements in multiple domains. All the programs targeted early mobilization occurring the first 24 hours and importantly 3 times each day as evidence-based strategy for better patient and system level outcomes. Early mobilization senior-friendly care models like ACE and HELP and ERAS have proven to result in meaningful reductions in hospital length of stay. Hospital-associated disability has widespread deleterious effects on patients, their families and caregivers and healthcare utilizations. And we always feel happy and proud that we are there to reduce the functional dependency and decline. And they feel the confidence when they are given this type of exercises, resistance training, where the old age people always believe that they can't do all these things. So that is from our side. I am having certain slides, but that's all just for later discussions and all. I think I have cleared the main part, and you can go through all these early mobilization protocols and everything through the John Hopkins site. They are having very education-based programs there. I think that's it.
Thank you, Dr. Ajishma. Actually, it was a nice topic, and it was very interesting topic for me, especially. I have one query. We does ICU mobility or early mobilization things we does, whether we have any particular protocol. See, one of the things which like I have seen and tried is pumpless therapy. Is it useful for geriatric population in the ICU?
Okay, so since our geriatric system is highly standardized, we are not allowed to practice anything which is out of our what is called our system. So this whenever we are giving more sophisticated system in ICU, what we do is actually three things we do. Number one, doctor has to make the patient less on medication and starts working on the sedation vacation. And our respiratory therapist, along with the doctors, makes that one. The next one is actually within 48 hours, the patient has to be at the edge of the bed, whether the patient is fully, even semi-conscious or something like that. So how we do is here is actually 24 hours early mobilization, verticalization, 48 hours edge of the bed, 72 hours out of bed. It goes like A, B, C, D, E, F. Just to mention, because most of the things are happening here based on the studies. We are part of many outcome studies. So to be honest, we have restricted type of but sophisticated type of early mobility practices here.
Okay. So you meant to say that you may take a RAS scale or sedation scale before mobilizing.
Yeah, exactly. CAM scale, RAS scales, all these things are mandatory according to the hospital policies. So it is always there. And we in the ICU, when we use this ICU mobility scale also. So RAS, CAM, ICU mobility scale together will give you the exact picture of the patient, how the improvement goes on.
Thank you, sir. Do you know if anybody is having question in YouTube? Like here, I have not seen any questions in chat box.
Yeah, we'll be checking, ma'am. No questions, ma'am. No questions there in YouTube, ma'am.
Okay.
No questions, but
Stalin sir also checking.
yeah, it's true. Actually, no. While he's presenting Dr. Hashim Shah, this functional disability along with the hospitalization of the geriatrics, we had an experience out of this. The residents in the geriatric nursing home for years. So if they go for like a hospitalization or a 1 week or a few days, then after that maybe 10 days, there is so much of functional decline on them, like developing a fast of this muscle tightness.
Exactly. And here in Qatar,
So much of functional decline. I've been in.
To be honest, in Qatar, people of more than 70 years are only 3,000 because the Qataris.
Okay.
But considering as a wealth, so they gives a lot of emphasis on.
Actually, I was in Singapore about a decade. So I was in a geriatric setup about 6.5 years. So I was working in the Orange Valley nursing home. Is one of the leading private nursing home caregivers. Private nursing home carers. So we do observe that this thing actually, if you go for any few days of hospitalization, also there will be a functional decline associated with geriatric residents. It is very well witnessed. It's really happy to have your such a nice presentation.
Yeah, I have seen a chat here. Kindly explain about why respiratory muscle weakness is prevalent among critical care geriatric patients. What are the physiotherapy? Okay, see, the point is actually when you are there in the hospital for 2 days itself, there is something called muscle mass, and it is very complicated pathology. So there is a sarcopenia develops, and sarcopenia is a generalized amount. It's actually, that is why the patient is getting weight loss. Am I here audible? I think, yeah. So the respiratory muscle along with all other muscles go for wasting, and it is sarcopenic changes, the pathological changes, as I mentioned earlier. So the point is actually, when in our facility, what we do is we concentrate more on early mobility. That means make the patient walk again. When the patient are walking, they have to breathe, they have to train, the diaphragm is in the normal vertical positions, they have to breathe, they can even nicely do the chest expansions and all. The respiratory therapy part, like what the suction, chest physical therapy, and all sort of things will be even more done by the respiratory therapist. We do the early mobilization and the strength training. Of course, there are certain studies going on with the respiratory devices, but in ICU, we don't use the respiratory devices like flutters and other type of things, but we have biofeedback devices for the respiratory training. But the team which is working along with the geriatric team is actually totally concentrating on the early mobilization.
It was a nice question. I can add something, sir.
Yeah, please.
Dr. Vijay Nambi, actually, it has proved that many studies has come out saying that within 48 hours of a hospitalization will lead to myopathy. So
exactly.
myopathy is meant for the whole muscles, including the respiratory muscles. And as you know, when you are lying down, even on ventilator or even normal room air or in oxygen therapy, you are actually assisted with your gravity. You are not breathing against the gravity. Exactly. Whenever you from the supine to the sideline itself, the ability of the muscles to work itself is going to change. So you can imagine if the person is on bedridden for 1 or 2 days, how much muscle weakness would have happened. It is not only in geriatric population, it happens even in normal population.
Yeah. Only in geriatrics, we used to say it is sarcopenic changes. Otherwise, it is sarcopenic changes. Exactly. Thank you for adding that.
Yeah. Thank you, sir. One more question.
Thank you. Have a nice day.
One more thing, yes. One more
early
question.
mobilization in ICU with the tracheostomy and specific don'ts to be considered. See, in ICU, there is nothing called a contraindication. There is everything is modification. You need a lot of experience to do early mobilization in the ICUs. We can do everything. We do mobilize with the patient who is in the vasopressors, to be honest. But like everything based on the current situations and all. So when the patient is in ICU who is in tracheostomy, what is the patient is the nurse having certain particular role. Like the EVD, when the EVD, we never opens and close the EVD during the mobilization. It is nurse duty, it is already policy set for that. Same like that, the tracheostomy care is nurse, we'll be looking after, our aide will be looking after the mobilization. We use a SARA combilizer out in the ICUs. And most of the patients will be mobilized in the 72 hours out of bed into the SARA combilizer, and the patient will be connected to the ventilator, as I have mentioned the photo earlier, because we don't want atelectasis to be getting worse and the patient is getting hospital acquired pneumonia and all other complications. So we have many deaths earlier, and because of these things, because we have many patients, we are obese because of a wealthy country, you can expect that obesity and diabetes is very high. So tracheostomy care is actually you have to and somebody there for the tracheostomy care while mobilizing the patient, but there is nothing specific don'ts. The point is actually, I have one suggestion I will tell you. We have many cases where the tracheostomy bleed happened during the mobilization. Actually, patient will not die even there is 3 second, 4 second gap. Even you can disconnect and put the patient back. If you are experienced person, you can put it back there. So we had certain cases of flushing the ventilator on the therapist face. So our therapist always wears a face shield, and we have certain injuries of tracheostomy bleed. But more than that, we don't have any deleterious adverse effects with the tracheostomy. In fact, to mobilize the patient earlier, we do tracheostomy very often, very frequently. So it is a normal part. When the patient is in tracheostomy, we feel more comfortable than the patient is through the endotracheal intubation.
Actually, before going for mobilization, even they does the secretions, they will remove it, suction it, so that aspirations can be avoided. That is one precaution they will take, but it's not contraindicated. Even in unconscious patients, we can mobilize. Vestibular mobilization we used to do with the tracheostomy.
If you have, you can see, I'm having another photos where we can see the patients who is comatose actually with all the supports and all. We'll be putting 1, 2, 3, 4 in the garden area with the doctors and nurses and all sitting aside. So that is a common view what we are seeing in our acute care and ICU areas.
Thank you, sir. It was nice and good talk.
Thank you for the interaction. Also, it was a nice interaction. Yeah. Okay. It's not a simple.
Same question, Asha. I also asked, like elderly population, whether they have any protocol. Actually, I think different hospitals. You have in Qatar different thing. If another countries will have different hospital setup depends upon thing. I think.
Exactly. And we are having early mobilization protocols. We are having geriatric mobilization protocols. Like that is going.
Thank you.
Okay.
Thank you, sir.
Nice.
Thank you, sir. Over to Duna and Chandra.
Thank you, Dr. Annie Thomas, madam, for setting time aside from your heavy schedules to share some valuable information with our delegates. Thank you. Dr. Ajim Shah, we rarely get such a kind of opportunity to listen to the words of great knowledgeable speaker. Thank you, sir. With immense pleasure, we invite our next chairperson, Professor Shiva Shanmugam, sir, who has completed his master's in orthopedics. Sir possesses more than 14 years of experience in teaching as ex-professor in BAMS, West Bengal, and JDT College of Physiotherapy, Calicut, India. Sir is also a member of Federation of Indian Manual Therapists, FIMT, currently worked as Bethany Navajeevan College of Physiotherapy, Trivandrum, Kerala. We welcome you, sir. We are so privileged to have you here to grace this event.
Good evening, one and all.
Good evening, sir.
Good evening. So it is a great honor and a privilege for me to be a chairperson in GERICON 2021. So I want to thank personally Magesh Babu sir and Chandramohan sir and other organizing team putting this much hard work to give to make this program very efficient and useful for the upcoming physios. And I'm very glad to invite Dr. Sanjay Samuel sir. He is a principal as well as professor from Lakshmi Memorial College of Physiotherapy, Mangalore, Karnataka. So, welcome, sir, for this wonderful scientific session. He is one of the eminent personality we all know and dedicated professional in the field of physiotherapy. Almost 20 years was spending his life in this profession, and he is a university topper in undergraduate and also got the post graduation from Manipal Academy of Health Education. Now he got a he done PhD in geriatric rehabilitation, and we all know the importance of geriatric rehabilitation. So due to the improvement in modern healthcare facilities and new innovations in the field of medicines, the life expectancy of the people keep on increasing, and the geriatric problem also by the side it is keep on increasing. So we need to find a way to approach the geriatric problems, and this is a topic Sanjay sir going to present here. He'll be sharing his ideas in his PhD activities also related to geriatric rehabilitation. He'll share his ideas and new innovations. So that will be helpful for us to get a idea to tackle the geriatric populations. So welcome, sir. Dr. Sanjay sir, you can proceed.
Thank you, Shiva Shanmugam, for that introduction. First of all, I'd like to thank Magesh Babu and Exercise Prescription Group for organizing this and giving me this opportunity to share a couple of things with all of you. I know it's quite late towards the end of the day now. I'm at home, so whatever disturbance which you will hear in the background obviously is not work related. Obviously, I'm back from work, so that's one side. Let's try to, my topic today, which I'm supposed to be sharing with you, is extended care. So before that, I'd like to put across that I'll be limiting myself to just the topic over there, contrary to what Professor Shiv Shanmugam was telling about my research experience areas. And I'm not getting into any of those things. I'm just sticking on to the small area, which is, obviously because the last session today. I hope all of you can hear me well. And let me just share my screen. Give me a moment. I've just shared my screen. Is it visible?
No, sir, not yet.
Hold on. Now?
No, sir. Yes, appearing, sir.
Okay. Okay.
Yes, sir. Kindly go for the full screen view slideshow.
Hold on.
Yes, sir.
Is it okay now?
Yes, sir. Okay now.
Just give me a moment. Let me go to a place which is a little bit more quieter than where I'm sitting right now. As I told you, I'm at home. Give me a moment.
Yeah,
One
okay,
second.
sir.
Okay, you're still with me? Hello?
Yes, sir. We can hear you.
And you can see my screen too, right?
Yes, sir.
Is that Duna from the organizing team who's talking?
Yes, sir. Myself, Miss Duna.
Yes, yes, yes. Thank you, Ms. Duna. And I think I've been chatting with you regarding the number of people who are
Yes, sir.
remaining at the fag end of the day. I'm pretty happy, and my heart goes out to all the people who are still attending. And I'm very happy to share a couple of things with the focus on extended care for older persons. That's what the topic which is given to me. What I would be doing is I'll just give you an idea as to what are the contents of what I'm talking today. The first, hold on. Okay, the talk would be scheduled like this. I'll be talking a few things about with the background of aging and functional decline. And I would touch upon the area of what we call as successful aging. And then we would go into the role of extended care in successful aging. And that itself I would be discussing with a focus on the need and the options of extended care which is available, and the differences which is there in high income economies and low and middle income economies, and finally coming down to India. So this is the layout of what I would discuss. I hope to cover it in the next 25 minutes. Even though the name of the session is extended care, I'm not going to extend much, I hope. So the background of today's talk is, of course, age-related functional decline. And to understand today's needs to talk about extended care, we need to understand that decline is happening in all three domains, which is of interest to me right now. Obviously, the first one as a physiotherapist, which is my primary lookout, is the physical decline. And then you have cognitive decline, and then you have decline in social capability. So overall, this is the background of what we're talking, and why we should think about the care continuum to be discussed. And of course, why all these things? Because the costs of looking after an aging population is increasing, like the way our petrol prices are increasing. And of course, the requirement for extended care is because aging is associated with a lot of chronic diseases. So we are looking at a situation where people are getting into the economic side of it, and therefore it's better to have a care continuum which is established, which is easy on the pocket as well as easy on the healthcare delivery system. Yeah, I can see a message on my screen. I hope it's not being shared. I'm reading it here. Move this window away from the shared application. I hope it doesn't show on your screen. Is it by chance showing there?
Something is just blinking in the background, sir. Please remove this window from here.
I know. I can see that as well. I've never encountered this. Can someone help me with this as to what it is? Because I have not seen this with a Zoom meet when I'm sharing as of this.
If you have got some kind of message box there in your screen, check. You just need to close that.
Yeah, I know. I don't see anything here.
Minimize the PowerPoint window. You might find it.
Hold on. Okay.
Just close that message box.
Yeah, I've done that. But still, it seems to be the same. Let me see.
The things are visible, sir. You can go on, no problem.
It's okay, right? It's okay.
Yeah,
That's
it's okay.
fine. Yeah, let's not spend time on that since our time itself is. Yeah, hold on. I'm just expanding that. Can you? Has it come back to the full screen? Has it come back to the full screen view?
Yes, sir.
Okay. So please don't bother about that. Whatever message is coming in the center. That's all I can do now. So anyway, so we're looking at the economic side of it, and we are looking at why there is a necessity for extended care. Of course, the age-related decline has its own concerns, especially for countries like India, because we are part of this huge landmass called Asia, where we are expected to have a big number of aging population to be there by the end of 2025. So out of this, it's even more scary. By 2050, what they say is out of every 6 of the world's elderly persons would be living in India. So that's scary. I mean, that's scary, and that's you look at it as from a potential point of view for people who are involved in rehabilitation. It's a huge potential too. Now there is going to be a greater demand for care and support services. This is what the ramifications of such concern in Asian countries is, and we are among the Asian countries with reference to aging and management. We still have a long way to go. So obviously we are going to be much more important for us to think as to what we should be looking at and whether we should have a model for extended care in place. And we have to actually introspect as to what models we have right now, if it's okay. Now then there's this concept of active aging. I like this word active aging personally because of course it's a concept deployed by the European Commission, and the WHO also considers that, because we are looking at productivity with reference to management of resources. So the definition for active aging is the process of optimizing opportunities for health, participation and security in order to enhance quality of life as people age. So we're looking at participation and security with reference to human resources. That's one way of looking at aging, and I personally like this much better than the other aspects of describing aging. The other concept is we talk about, I mean, of course, same thing to do with that. That's active aging relates to the idea of longer activity with higher retirement age and working practices adapted to the age of the employee. So we are looking at the economic side of it. We are looking at staying healthy for being productive and staying healthy for a longer period of time. So that's what active aging is all about. The other concept which you will read when you are looking at aging literature is successful aging. Now, successful aging, as the term indicates, is a multidimensional concept. There is a biomedical model and a socio-psychological model involved in that. The operational definition of successful aging is to maximize potentials and minimize negative effects of getting older. So it's all about looking at the physical, mental, and social abilities and how to maximize the potential when there is a decline. So that's what is considered under successful aging. Now, what does the WHO say? WHO looks at two distinct functions when it comes to aging. One is the intrinsic capacity and the other is a functional ability. Now, these are the factors that contribute to what we call as healthy aging. So, you're looking at intrinsic capacity with a combination of an individual's physical, mental, and psychological capacities, and functional abilities is a combination of interaction of intrinsic capacity with the environment. So, WHO says that these are the factors which need to be considered when you're talking about healthy aging. So, I just talked to you about active aging, successful aging, and what we call as healthy aging. This is something which we all need to understand. Most seniors want to age successfully and safely in their own home. That's kind of a wish which everyone has. I was listening to the first speaker today, Dr. Sheetal. She was also focusing on this, that it's better to keep people from getting institutionalized, at least in a country like ours, that delay that such requirement for institutionalization as much as possible. That's the lookout which we should have. So, but unfortunately, that desire must be weighted against the possible risks. So, if you're looking at people who are aging, and if they are not safe in their environment where the aging is happening within their own confines, then you need to be concerned, because you might have questions like this: does the senior have access to caregivers? Can the home be made more safe? So these kind of questions need to be answered if you're looking at the aging successfully in the safety of your own home. Extended care, primarily, even though it's called extended care, the extension should start from home. So that's a category which we call as in-home care. That's because for all reasons, all of us wish to grow old in our own comforts. So that's the wish everyone has. So you need to have peace of mind. You want to stay at home. That's the first choice for all of us. Now, but the problem with this is that in an in-home care, recovery may or may not be optimal when it comes to the issue which is related to aging, a pathological. I would not want to say pathological. I would want to say a physiological change with aging, which has happened, which is beyond what the person can manage. It may be difficult at home. So, another thing to consider is at home, the caregivers are obviously your family or friends or healthcare providers from an outside agency. If that situation arises, we're talking about social security and all that stuff. And most of the times, the extended care burden for an in-home care is going to boil down on the family and at the most friends. So this is going to be some concern which we have about in-home care. Otherwise, please remember, extended care starts from home. The second distinct area which we all may want to think of is daycare. Now, daycare is, since we're talking about elderly persons, as WHO's definitions seem to be indicating. So, adult daycare provides respite for caregivers and a welcome change of scene for the seniors. So it's like a time pass, I would say. I mean, that's on a lighter side, but primarily it is a respite. So, in daycare programs, you can diverge into two areas. One is a social model or a medical model. We're not going to discuss all that in detail, but just to give a brief idea, social programs are those which focus on on providing companionship or hobbies or special interests or such things, which is primarily looking at the social domain of the person. And the medical programs in daycare focus on providing therapies like dialysis, ventilation, and of course our core area, which we talk about, is rehabilitation. So social programs and medical programs. Many times it's a mix-up of these things, but unfortunately, like oil and water, many times the mixing is difficult. Now we're looking at the assisted living centers. Now, obviously, as what the picture looks like, it's a picturesque stuff there, but it involves money. But so most of the next few slides that I'm going to have is obviously from the what we call as a high income economies. And in this case, I've taken the examples from the US, from available literature with reference to New York state as to how they work it on, and of course some more few things from there, because we need to have a benchmark as to what we're talking about assisted living centers. So assisted living centers in all its glory are for people who prefer to live independently. They want to be a part of a vibrant community, which is a slightly different than what we talk about the community living in the normal life. And then, of course, you also want to have you also want them also to have some avenues for personal growth. So if these three areas is your checklist ticking, assisted living centers, and if the facilities are available, that would be the best thing to do. And that's what high income economies appear to be focusing on. And the facilities are improving by the day. These are places where people who are less than independent but not in need of a full-time care, these are the people who can be there. And it's a proper care option, typically employed by the elderly who do not require a 24-hour health care, typically required for what we call as a typical old age home or elderly care facility. So these are places which are relatively, it doesn't look like a nursing home. They're a polished version of things where people need to be eligible to be around also. You can't have people with much morbidities to be part of it, but it gives help in housing, support services, and healthcare on a needed basis. So that's the concept of assisted living centers, which are already in place in the high income economies. And the setting is similar to a person's own home, or they try to make it as close to our own home that it appears. And there is entertainment, there is housekeeping, there is all kind of lifestyle supports, depending on what is the paying capacity, and depending on what is the economics which works from the state's point of view, etc. So the senior gets the security of having assistance when needed and residing in a structured environment while maintaining an overall stage of independence. So we are looking at something which is similar to a person. It's similar to his own home, but you have things provided, and you are basically more of a consumer when it comes to this, and you are participating in your process of active aging. Let's not, for want of time, let's not detail much, but we are talking about socializing your food, nutrition requirements, your domestic chores need to be given a break. You've done it till you retired. Now is the time you retire from that also. So that's the kind of thing. And then you're basically looking for an active and independent lifestyle. That's a focus of these assisted living facilities. They're pretty popular in high income economies. I just want to look at only one point over there in the slide. The major drawback for this is the cost. So obviously somebody has to pay for it. Now, who pays for it is a question, and there are different mechanisms by which this cost is shared in those countries. That's what we generally need to understand about assisted living. Let's skip a couple of slides there. Some of them actually look like these. This is what I understand. So in those high income economies, or in what we call as in developed nations, most of the assisted living facilities are kind where you are actually surrounded with warmth and luxury, wherein you are in a position to actually entertain. It's not that you are living in a place where you're kind of demoted into a degenerating soul. You are rather you have the continuum of being alive and even in a position to entertain when you're growing old. Apart from that, I'm just going to skip into all these slides. I'm just going to name them. I'm sure all of you can find it from the literature. Now, the types, the options of assisted living are many in those developed nations, ranging from independent living apartments, adult homes, enriched housing, family type homes. So they have individual differences, and depending on who pays for it. For example, family type homes in the US, the payments or the operational networking is done by the Department of Social Services. So on the other hand, The State Department of Health is the one which requires a license and enriched housing facility. So these facilities which are there, they look similar when you're reading them, but they are actually different because the management is done in totally different ways, and eligibility for each of these things are also determined in with specific objective criteria. Yeah, of course, we need to understand the assisted living program as such is an excellent alternative to nursing homes. So that is why those countries have actually gone into that, because these are people who are, not so sick, not so dependent, but then the concept of independent living in them is so strong that they obviously can be at risk living independently. So these programs, they are funded by social security based schemes. In the USA, for example, Medicaid, supplemental security income, and home relief. So these are the categories where as you're working, you're paying for it, and then after you retire, you have a co-payment option, or you have a fully funded option, depending on what type of housing in assisted living program you take. Now, they also have what we call as continuing care retirement communities or life care communities. Again, pretty interesting because it's about aging in place. That means you can decide, or rather, there is a possibility that you can upgrade your requirements for assistance, or you can downgrade them depending on how your general health is. So your advantage is you're sticking around in a familiar surrounding. You will have options of all kinds. So the whole thing obviously is determined by money. So the payments are usually in monthly payments, in co-payments. The services and amenities which are required and the medical care, they are all shared in their costs by either the state, partly or fully, or co-payment from the person who is taking these facilities. So continuing care retirement communities is very popular, and they are growing leaps and bounds to the extent that every year new additions have been coming up in that. Now, why we are talking about all this in staying in India, we'll come back to it now. Let's look at let's get the perspective clear. That's what we're talking about. Okay, then we have nursing homes. Now, nursing homes is not confined to only HIEs or high income economies. We also have nursing homes in low and middle income economies too. Now, nursing homes typically is after a hospital stay, somebody who cannot live independently or they require some nursing care, which includes rehabilitation, are the kind of place people who are fit to be in nursing homes. Now, the only thing which demarcates HIEs and LMIEs or high income economies and low and middle income economies is the state of modernity of such nursing homes. So the state of art communities, which are the modern nursing homes, which are staffed by a team of medical professionals and others dedicated to quality care. Now remember, this is where most of the physiotherapists who are, the job vacancies for people who are going from India, many of them do work in these state-of-the-art communities, and you really can't compare such facilities to what we call as a nursing home here. So even though the title is same, nursing homes range in their facilities and their state-of-art facilities, depending on obviously the buying capacity of people. So we need to understand nursing homes are a mainstay for both these type of countries. Then you have the other category called skilled nursing facilities. Now, skilled nursing facilities are slowly getting much popular in our country also. Now, this is where we are talking about managing people with specific health problems like traumatic brain injuries, dementias, or anything where dependency is a significant concern, and you can't really manage them in a conventional nursing home. So these are places where you require specialist services of varying kinds. Now, depending on that, you have skilled nursing facilities. In developed countries, most of the time, skilled nursing facilities are kind of a transition for some of these post-op patients who are otherwise community living, but they spend their time for recovery in the acute care or probably even the subacute phase of time, and that short term of the nursing home stay is enhanced in the care continuum by ensuring that they are put up in a skilled nursing facility. So nursing facilities and skilled nursing facilities becoming an important mainstay of extended care. Let's skip these. Then you have the other category of what we call as hospices or terminal care, or sometimes also called palliative care homes. So these are again increasingly becoming popular in countries like India. They've already been part of the the healthcare delivery system in HIEs, high income economies, for a long time. Palliative care now, with philanthropic supports, with government aid, all that categories are slowly but steadily increasing in our country also because of morbidities associated with cancers, with debilitating illnesses of all kinds, which is creeping into our population thanks to the lifestyle differences also which we are undergoing right now. So extended care there's a specific focus on palliative care and or terminal care in that. Yeah, we can skip this because, of course, the concept of palliative care is it's mostly about high quality pain and symptom management, and it's going to provide support for patients. So it becomes difficult for them to be managed at home. So in-home care as well as even nursing care becomes difficult in situations where pain is a big concern, and morbid conditions which have got significant functional disabilities and pain. So these kind of patients can be better managed by palliative care programs. So they typically alleviate suffering. Now, what's the future of extended care in all these economies as well as what we are in general? So there is a paradigm shift in seniors' health, safety, and sense of well-being in the years to come. That's already started, and we do have seniors involved in planning their own care even right now. And there is a growing demand for cost-effective housing. So it's like extended care limiting to a four-walled nursing facility is not what we are looking at now. For example, the HUD grant system in the USA, they are looking at possibilities for elderly people in sponsored or low-income housing. So that means the co-payment option, the payment from the patient side is being reduced to the extent that a lot of state funding goes into people who require assisted living. So it's pretty interesting a model, and how they make it cost effective obviously is by ensuring that these facilities are covered by more and more Medicare providers. So that's kind of a future which they are looking for as high income economies. Now we need to understand, obviously, since we're here in India. Did I hear someone saying hello? Do we have a question? I don't have the screen right now. So is there any question somebody has midway? Hello? Can you hear me?
Checking, sir.
All is well?
Checking, sir. Yes, sir, all is well.
Yeah, okay.
We'll be
All
checking,
right,
sir,
so
if there is any question.
that's fine. Thank you. Now, that all said related to the good, bad, and the ugly related to extended care, we need to understand the East and West differences. When I say East and West in aging, I'm talking about the cultural differences and the differences which is perceived in the populations on aging. Now, Asian countries typically tend to apply aging theories which are developed by the West, which is a big no, because Western culture, if you look at it, they stress on independence and autonomy. In contrast, Eastern cultural values, which is related to ours also, there's a lot of cultural value attached to living with elderly dependents. So this is a big, I would say it's a dichotomous situation. So you can't really pick in a model which is successful in the West and try to ape it. So that's something which, unfortunately, many a time most of us do. We need to understand why. Now, I don't really have the time to talk about the aging theories of Western and Eastern. People who are interested must go through this. So the Western aging theories and Eastern aging theories, right? It appears interesting, and they are distinct. So the concept of perceiving yourself as dependent or independent, they're totally different in Asian population and the Western population. So this is something which has been deliberated, and a lot of theories have come in. So those who are interested, please, I would suggest you to read the aging theories. So since there are differences, so we are looking at those differences to be considered when we are looking at extended care, when they are to be applied in Asian low and middle income economies. Okay, now focusing on India. Now, what's interesting about Indian, cultural values is that we still seem to be having strong cultural values pertaining to the care of elderly. Uh, and then the next part of it is our social security system is not that great. Okay, so these two factors, they are the reasons why a vast majority of older adults are in India are community living. Now, when I say community living, these are people who are living with their children, or if they have children, or some kind of a system where social connections are there. It is not that they are an old couple is staying on their own, or an old man is staying on their own. The children have gone. There's an emptiness syndrome. All these kind of things are not much applicable because of these two things. Now, are they all good or are they all bad? It's something which we have to decide. But as of now, it looks like these two factors. Now, what is our concern now? Why are we talking about extended care, and why are we talking about these cultural values, etc.? Because in such community living people who have got, whose dependents feel that it's necessary that they stay with them, but they don't have the kind of resources to take care of them. Morbidity, when it comes among this population, it becomes a big issue. So that starts eating away into the income of such families, especially when there is not much of disposable income for the care of these elderly. So influencing the financial and social well-being of such households becomes a big problem, which is created by morbidity among the aging population in India. So this is our major concern. Now, why is it a concern? Because this ultimately leads to what we call as conflicts. So there is limitations imposed on family caregivers. Sometimes it could even go to the extent of posing a significant challenge to the family's network itself. So you start looking at aging as a burden, or like somebody, I don't know who said this, aging is an unwelcome guest. Okay, so that kind of situation is something which we'll easily lead into if at all we are looking at institutionalized elderly. So now the concern which we have is even compounded by the changing family structures in our country. Of course, I already talked to you about lack of social security network. So these two factors, they are getting into a new trend of increasing institutionalization. A couple of evidences are there which talk about joint family structures which have been broken down. Increasing dependency caused by functional decline is a concern. So these factors have led to the unwanted kind of, since I'm talking from an Eastern cultural point of view, an unwanted trend of institutionalization. Now, why is it so? Because institutionalization in this country at least has got a stigma, because we think that old age homes are some kind of, it's like those Charles Dickens novels, so we don't want that kind of place, and that's something which people dread. So that is why the stigma, that is something which needs to be broken down. There are different ways of doing that. Let's try to understand a few of that. So the first thing which we need to understand is we have to adapt the CPGs from those countries which we have been happily adopting. There's a difference between adaptation and adopting. Adopting is always secondary, as in any case. So we need to adapt these CPGs, or clinical practice guidelines, before simply aping from the West. Just because you find a lot of journals, a lot of articles which talk about aging, which talk about extended care, assisted living, we want to apply it here. It's difficult. So generalizability of findings from literature from this Western context is definitely unsuitable. So what is the role which all of us should be playing in the next couple of years is to enhance our evidence-based rehab planning in extended care. Because if you really look at the literature in India, it's quite, I would say, negligible when it comes to literature on evidence-based extended care. So in developing countries like ours, that is the necessity right now, and that's what we should be focusing on right now. Now, even though that's our lookout, this is my view that I think we should focus. Now, if we are still considering the the Eastern cultural values, so let's try to keep our focus limited to 4 areas. Number 1, in-home care. Number 2, daycare. And for these 2 categories, for people who are, for elderly who are less than independent, but not in need of full-time care. Now, how do we improvise both these things? It's not that in-home care is not happening. In-home care is happening now, but how do you make sure that the potentials of recovery for the patients who are undergoing in-home care is optimized? That's our lookout, which should be there right now. Again, for daycare institutions in India for elderly, pun intended, it should not be a time pass place where people go and sit and read newspapers and play cards only. Of course, those are required. I told you the importance of socialization in these daycare programs, but you need to enhance their facilities to ensure that recovery for a person who's got some dependence. The second 2 categories which we have to enhance about extended care in India is our skilled nursing facilities and palliative care. Now, believe me, when I have had the I've had the opportunity to visit a couple of skilled nursing facilities in different parts of this southern part of the country, and I've really found the skilled nursing facilities to be quite different from what we read in the literature about what they should be. So there is a big scope of enhancement of such facilities, and honestly, the main problem over there is rehabilitation professionals. See, nursing care actually happens, in most places by trained nurses or at least somebody who's an extended care worker. But rehabilitation, all kind of nonsense happens in the name of rehabilitation in such facilities. And I shudder to think about rehabilitation facilities in palliative care. So these are the 2 areas where our evidence backup as well as our clinical practice guidelines for such organizations are very, very poor. So I feel these 4 areas should be the focus areas which we have for Asian countries, Asian low and middle income economies like India. So of course, it is not to be limited to these 4. You can always develop on assisted living facilities, make it 5-star and make it an entertainment unit, like the couple of things which we saw earlier. It's going to happen. It is going to come in the next couple of years. But till then, I think these 4 at least should be our core areas of focus. So we need to definitely, I would like to conclude like this. We need to have a need-based and evidence-based extended care in order to promote what we call as active or successful aging. Now, if you want aging process itself to be successful or active or whatever, different people have explained with different contexts, you have to have evidence which is related to your country. It should be country specific, it should be area specific, it should be culture specific. So you need to develop on that evidence. And of course, need based. There is no point of focusing much about assisted living if the need can be minimized. If we can still hold on to our Eastern cultural values, wherein we respect our elderly, we want to keep them with us. So that's again, the need has to be again ascertained, and you have to look at. So there is a lot of elements which are involved in that. So these are the factors which we have to look at now to help people live more comfortably and to provide the best possible quality of life for people who are aging, as well as, don't forget, their families also. Thank you very much. Thank you all for listening to me. We still have 28 souls inside. I hope they are
Thank
happy.
you, sir.
Thank you.
People are watching in YouTube also, sir.
I understand. We had a chat with one of your organizing team, and she enlightened me saying that, not all that.
She conveyed it me, sir. Just now I checked that there are more than 1,250 people watched the morning session itself.
That's pretty good. Very impressive. I really hope people take these things further, because there are a lot of things to be done in geriatrics, honestly. If you give me 2 days, I can speak at length. But then, of course, thank you everyone for having the patience to listen to me, and I'm open for questions now.
Yes, sir. Thank you.
I'm not going to keep my video on because the place where my disturbances are less, my background may not look very nice. I'm talking about.
No problem at all, sir. No problem at all.
So I'm going to keep my mic muted now. I'll wait for a question and then I can answer one by one. Thank you very much.
Yes. Sir.
Thank you, sir. Nice presentation. So we'll be waiting for any queries or there any doubts. Up to now, no questions came.
It will take another 20 seconds from YouTube to finish our talk. Let us wait for another 20 to 30 seconds. And dear participants, those who are watching in YouTube, if you have any queries, kindly post it. We will be posting your queries in our Zoom chat. And of course, I'm very happy to see Siva Shanmugam after a very longer, yes, after 2020, almost going to be 20 years. And nice to see you.
Okay, sir. Okay, sir. Yes, sir.
I hope the content of what I spoke is was what is it, simple enough for people to gather.
Yes,
and I presume that's why we have no questions. I'm just waiting for that in case anybody has to ask. If not, I can just share.
Any questions?
No questions posted here, sir.
Yeah,
Yes,
I just like to share one more thing.
Yes.
I've been fortunate to discuss this, economics of aging with a couple of people from a few LMIE countries, low and middle income economy countries, as well as a few of the high income countries. And I really felt our evidence, as I was talking in my presentation, our evidence is something which is really requiring a lot of boost. So people who are listening from everywhere, different parts, hopefully, of the country, as well as maybe outside, I hope you can contribute in some way or the other to, take care of this deficiency, and we'll have more, it will be more credible. What we talk in terms of what we do will become more credible. I'm talking about the interventions which we do, the planning, the clinical care planning which we do, etc. in aging. They will all depend on how credible our, measures are, and the credibility is measured only with evidence. So that is something which we need to focus on. I hope the message which I put across is clear enough, and let's hope people take it further. Thank you very much.
Yes, sir. No questions in YouTube and no questions in Zoom. And I request MC to carry forward.
Thank you, Dr. Sanjay Samuel, sir, for setting time aside from your heavy schedules to share some valuable information with our delegates. It was indeed a knowledgeable session. Thank you so much, Professor Shiva Shanmugam, sir.
Thank you, ma'am.
So that marks the end of today's sessions.
Thank you very much.
Now I invite Mr. Jasil, Assistant Professor, SACPMS, to summarize the session. Thank you, sir.
Hello, good evening, everyone.
Yes, sir. Please carry on.
GERICON 2021, the inaugural session was started by 8:10 with a prayer by the college choir, followed by the welcome speech by Professor S. Magesh Babu, sir. Secondly, the speech was given by our Honorable Chairman, Mr. Anil Kumar, sir, followed by the inaugural session by our Chief Guest, Professor Dr. Ali Irani. And we had a various session by various distinguished guests from different departments. Moving on to the scientific session for today, we have a session 1 chaired by the Dr. P. Satya and speaker Dr. Sheetal Raj on topic comprehensive geriatric assessment. Madam had given a very good insight into the how to prioritize the treatment for senior citizens, as well as collected a lot of subtopics such as functionability and how to manage healthy aging evaluation of older adults, and benefits of comprehensive geriatric assessment. So it was a very good session. And session 2 was chaired by Dr. L. Gladson Jose. The speaker of the session was Dr. Dinil Pillai on the topic TT in aging spine and surgical spine. Actually, sir had made everyone aware of how to handle a spine surgery patient and the follow-up, how to give a follow-up and handling various risks and complications. Sir also has in prioritized how to go for a differential diagnosis of the various topics, various conditions, sorry. And the session 3 was chaired by Professor Remia, and the speaker of the session was Dr. Annie Thomas on a topic adaptability in community among neurogeriatric conditions. Ma'am had addressed a lot of physical as well as mental health of well-being for patients, and also Madam has addressed how to give for a planning of various problems, how to manage for a crisis management, self-management, disability management. Also, Madam also had covered a topic of integrated therapy for the geriatric populations. And moving on to the session 4, the chairperson of the session was Dr. Jibu George Varghese. The speaker of the session was Girish N. On the topics covered on the topic balance and falls. So, sir, I have covered a lot of aspects on postural control as well as the physiology of balance, identification of balance issues, and a lot of balance tests, and managing of balance issues in geriatric populations. With this, we had completed the forenoon sessions of scientific session. Thank you. Thank you, sir.
Maheshwar, your audio is not reaching us.
Kindly unmute Stalin, sir. Yes. Stalin, sir, you were again muted. Please unmute and speak.
Yeah. Can I? Okay.
Yeah, we can hear you.
It was a pleasure and it was a great day to know the honors, guest of honors of this today's session. And my colleague Jessil introduced about and talk about the morning resource person. Yeah, coming to this afternoon session, actually is very, very glad, and we are really privileged, and we really enjoyed the sessions being taken by the various resource persons. So this afternoon session is start off with Mr.
Muhammad Yasir, sir.
Yeah, Muhammad. Where is it? Yes. This afternoon session is start off with Dr. Muhammad Yasir. This topic about inflammation of inflammation redox imbalance and the effects of self-management in the ONE. So in the second session is this is a chat by Dr. Chandra Mohan. The second session was Mr. Shyam Krishnan he's nailed the performance. Actually, is in-depth in-depth lectures been taken by Dr. Shyam Krishnan as assistant professor of KMC Mangalore about degenerative joint diseases in elderly, which chaired by Dr. Manisha A. Rati. So it was a very wonderful session in-depth knowledge about this osteoarthritis, which is we may not seen in terms of pathophysiology, in terms of assessment and the management part. And there's another session is a third session is done by Dr. Ajim Shah. Is a renowned resource person. He's been in Qatar Petroleum. So he took a topic of this critical and acute geriatric care of geriatric care in the geriatric population. Which the session is chaired by Dr. Annie Thomas. So it was really a fruitful, and it is a eye-opening session for this. There's a different topic in geriatric management. It's a critical and acute geriatric geriatric care. So that is he's highlighted the thing like disability associated with hospitalization. So really, we really benefited a lot of this session. Then finally, today's session is ended by Dr. Sanjay Iban. He has a very nice lectures giving an extended care of older population, chaired by chaired by Dr. Sadas. What is his name?
Shiva Shanmugam, Professor.
Yeah, Professor Shiva Shanmugam. Yeah, Shiva Shanmugam, sir. Oh, okay. So the whole afternoon, as well as morning, as well as afternoon session was very fruitful, and it was a very nice session. So thank you, and thank you one and all again for your, all the resource persons who made this day. We're grateful, and gracious the occasion of this international conference. Thank you very much. Over to Chandramohan, sir.
Thank you, Stalin, sir. And tomorrow we all have the first session by 9 a.m. and not like today. We will be having a less topics tomorrow and no rushing. And we will be having a paper presentation in the afternoon. And I request all you join by 9 a.m. sharply, so that after a small summaries of day 2 topics to be discussed, and we can start the program. I thank Duna Madam for her wonderful support, and I thank Professor Mahesh Babu sir and faculties of Sri Anjaneya Paramedical Sciences. And I thank all participants for patiently attending the programs from morning to this time. I know that it was a lengthy program without much breaks between lunch also. Actually, it was a very less time. Actually, it was not a break for us, but participant might have taken. And thank you, everyone. Thank you, everyone. Let us meet tomorrow morning by 9 a.m. Over to Mahesh, sir.
Thank you, sir. And thank you, Mukesh, sir.
Yeah, say bye to all, sir. And bye-bye all. Bye, Duna.
Okay. Bye-bye, sir.
Thank you, sir. Thank you, sir. Thank you, ma'am.
Thank you, ma'am. We'll be winding up the session for today.
Thank you, ma'am.
Meeting you all tomorrow morning at 9 a.m.
Okay, thank you, ma'am.